We are live, sir.
Okay, all videos off and the mics off. Good evening, everybody. National Diabetes, Obesity and Cholesterol Foundation and Fortis Doc Hospital for Diabetes and Allied Sciences present to you Ahuja Bajaj Symposium 6. It will be today evening and tomorrow morning. And we have excellent program for you. Varied speakers, varied topics, new topics, nutrition topics, and lots of international speakers. So please enjoy in the evening and tomorrow morning. Just to introduce, if some of you may be wondering who are Dr. Ahuja and who are Dr. Bajaj, these were two exceptional gentlemen, both professors of medicine at All India Institute of Medical Sciences, and I was fortunate enough to be trained under them. Professor Ahuja was founding member of Research Society of Study of Diabetes in India. It was his idea to start this. And he was one of the most decorated medical personnel at that time, and his medical series Progress of Diet in Medicine was very, very popular and read by all of us. Professor J.S. Bajaj was exceptional person with exceptional intellect. Any award of medicine and science he got very early in his career. He was physician to multiple presidents and prime ministers, and as a scientist and as a medical person, he was par excellence. I happened to be taught by him for several years, and when I visited UK and USA, I have not found a single person to match his intellect. So, based on our our you can say appreciation to them, not only me but multiple other people who are participating in this symposium, who have been their students. This series was established 3 years back, and this is sixth in the line of series that we are presenting to you. As far as National Diabetes, Obesity and Cholesterol Foundation and Fortis CDOC's Hospital for Diabetes and Allied Sciences, this is my team who have contributed much to the research and education over the years. So my contribution is minimal, their contribution is maximum. We have been helped by a number of other excellent researchers, national and international. We have done a number of research studies with many of the people. You can see our research has grown over a period of time. This is the, if you see Google Scholar, this is from my name and NDoc. You see the increasing number of citations for our research over a period of time. And this is maximum this year. And that's because we have been rapidly and comprehensively doing research, not only on diabetes, but diabetes and COVID-19. You can see our research team working at a separate area than Fortis Doc Hospital. And you see a number of publications, international consensus, I was part of it. There are 2 papers and number of highly cited papers. Look at these 2 papers. Clinical consideration for patients with diabetes in times of COVID-19 epidemic, 228 citations since April, May. This is one of the fastest uh, cited paper as far as I'm concerned and as far as many other people are concerned. And chloroquine and hydroxychloroquine in treatment of COVID-19 with or without diabetes, 257 citations since April, May. We have published on many other aspects during this time, including a new body composition index, heart failure in South Asia, and so on. In addition to that, our team, led by Hema Gopalan and Mr. Huck, has been doing a lot of work in the underprivileged areas. You see, this is a education program going on in the underprivileged area, and you see our customized diabetes vehicle where food testing is being performed. This is the currently ongoing program, screening and management of gestational diabetes in underprivileged population Delhi, and see all these women being trained and educated. And these programs have been funded by World Diabetes Foundation, Denmark. Exemplary work by all measures. And in addition to this work, there's a lot of publication in underprivileged area as far as diabetes is concerned, as far as gestational diabetes is concerned. And in addition to that, we have called for very strict glycemic control in the times of COVID-19 epidemic for all physicians, comprising from various top names from all over India. Also, top nutritionists have combined together with us to produce this paper, Balanced Nutrition is Needed in the Times of COVID-19 Epidemic in India, Call for Action. These papers have propelled many physicians and nutritionists to look at their patients more carefully and get their diabetes under control so that they are not afflicted by many complications of COVID-19. As a result of all this research by my colleagues and myself, we are fortunate that in this Stanford study, which was published in PLOS Biology, of top world ranking of top 2% of scientists, 5 Indians have been selected, and I'm fortunate to be part of these 5 people. But this is not because of me, this is because of my team. This is not one day's work. This has been years of very hard work in the hospital, in the research rooms, and in the underprivileged area. Finally, a lot of people have registered for this conference. Those who are attending, please write to koeldattac@gmail.com. Please write it down. If you want a free copy of my book, Diabetes in Delight, which has very useful and in-depth discussion, not only on diabetes, but also diet, exercise, everything. This is a 250 pages book and will be useful to many people. So with that, I finish my presentation and once again, invite all of you to enjoy the academic feast, excellent lectures by our national and international speakers. At this time, I invite Dr. Ritesh, Additional Director of Fortis CDOC Center for Diabetes in Delhi. Ritesh, please come in. Dr. Ritesh is not only expert in diabetes, but also a very well-respected expert on male hormonal disorders and has an in-depth knowledge of insulin pumps. I'll hand over this mic to Ritesh, and who will carry on the rest of the ceremony. So thank you all and enjoy.
Thank you, Dr. Mishra, and I welcome you again. We'll start without much ado with the first session, which will be taken up by my friend Dr. Naval Kishore Vikram. He is a professor in the Department of Medicine at All India Institute of Medical Sciences, New Delhi, and he has worked extensively in the field of obesity, metabolic syndrome, and non-alcoholic fatty liver disease. So I invite Dr. Naval to present his talk on muscle loss in diabetes, how to tackle.
Thank you, Ritesh. Thank you, sir, for giving me the opportunity. And that is a big responsibility to open this prestigious symposium. So I'll proceed on to my presentation. So all of us would have come across our patients coming to us with these kind of questions that I could walk, I could run before I was diagnosed to having diabetes, but now I don't have any other problem, but I just feel very weak. And this is going on as the years are passing by. So all these patients have what is diabetes related loss of muscle. Now, so the relationship between type 2 diabetes and sarcopenia and aging is very close. So insulin resistance and anabolic resistance, these are the two most important features which are occurring in this condition. Insulin resistance impairs the ability to decrease the breakdown in the fed state, whereas anabolic resistance, it decreases the ability to synthesize more protein, more muscle protein. So muscle, we all know, is the largest organ which has the glucose utilization in the body. So lower glucose utilization will contribute to further exacerbation of hyperglycemia, and along the way, inflammation and accumulation of advanced glycation end products also contribute to this. So the relationship between diabetes and sarcopenia is bidirectional. One may cause the other and exacerbate also the severity of the other illness. Now, this is the what this figure here shows the postprandial anabolic resistance concept. See, normally what happens after the meal, there is a anabolic response, muscle protein synthesis occurs, and in diabetic, this response is blunted. Now, so diabetics are more prone to develop sarcopenia. It has been studied in several longitudinal studies as well as cross-sectional studies. And here is just a meta-analysis of the studies, which shows that definitely the diabetics are at almost twice the risk of developing sarcopenia than non-diabetics. And this is more so in patients who have micro or macrovascular complications than the diabetes patients who do not have these complications. So this is just our study, our data, which we can clearly see from the here in the prevalence of low appendicular lean mass index and confirmed sarcopenia. So this is as compared to the normal glucose tolerance, we see that the prevalence in diabetes, both males and females, is quite high. So now how to deal with this? Now in diabetes, the main approach is weight loss, calorie restriction, and exercise, apart from the medications. Whereas in sarcopenia, nutrition and exercise are the cornerstone of management. So how do we combine these two approaches in a diabetes patient with sarcopenia? Now, protein consumption, increased protein consumption is the key. That increases not only the protein synthesis, but also decreases the breakdown, and which helps in improvement of sarcopenia. But also this protein is helpful in managing type 2 diabetes because it increases the insulin sensitivity and satiety, thereby decreasing the blood glucose levels. Now, branch chain amino acids such as leucine, isoleucine, and valine have been studied extensively in terms of sarcopenia, and it has been shown that they increase the protein synthesis and attenuate the muscle loss. Leucine is the one which has been maximally studied. It acts not only as a trigger, but also as the substrate for the protein synthesis. And the systematic review and meta-analysis have shown that supplementation with leucine increases the muscle protein fractional synthetic rate. Now, do all these protein sources fare equally when we come to increase in the muscle protein synthesis? No, because this figure here shows the difference between the protein with the animal origin versus the plant origin. And we see that the proportion of essential amino acids, and particularly this shaded area as for the leucine, you see that it is much higher in the animal sources, and the whey protein is considered to be having the best composition or the best proportion of essential amino acids and leucine as compared to the plant sources. Now, hydroxymethyl beta methyl butyrate. Now, this beta hydroxy beta methyl butyrate, or HMB, it is a key metabolite of leucine, which has been shown to have positive effects on lean body mass, and it stimulates protein synthesis and prevents breakdown. Now, an Indian study from the southern part has shown that there is an age-related decline in this HMB levels from childhood to older age, and that these levels are positively correlated with the lean mass and the muscle strength. So this interest in HMB has led to several studies, and this is the meta-analysis of 7 randomized controlled trials of HMB supplementation, which have shown greater muscle mass gain in the intervention groups than the controls. But there was not significant change in the fat mass. But apart from the amount and the quality of protein, a distribution of protein intake in the meals is equally important. That is very essential for having a maximum protein synthesis, because there is a window which is there about the maximum protein synthesis. And if we see here, that is the daily intake of protein is equally divided into 3 meals, then there are more chances of achieving that window of protein synthesis, rather than if we have uneven distribution, that is the major part of the protein is taken at one meal. So the chances of achieving the protein synthesis is less. So the distribution is equally important. Now, coming on to vitamin D in sarcopenia and diabetes, we all know that vitamin D deficiency is much more common in patients with diabetes than non-diabetics, and it can also affect the glycemic control. The effect of vitamin D on the muscle is mediated by the vitamin D receptors. And this deficiency of vitamin D, we all know, is associated with increased risk of sarcopenia, fractures, and frailty. Now, supplementation of vitamin D not only improves the glycemic control, it also improves the muscle function and muscle strength. And this has been studied in various cross-sectional as well as the longitudinal or interventional studies. In addition, it has an anti-inflammatory role. But the analysis of most of the studies has shown that the benefits of giving vitamin D vitamin D supplementation are achieved only in individuals who have deficient levels, but not in individuals who have adequate levels. So there could be a possibility of a range of vitamin D status which may be required to achieve the maximal benefit with the vitamin D supplementation. A combination of this with other nutrients has further shown to achieve greater benefit. There has also been interest in long-chain polyunsaturated fatty acids, particularly omega-3 fatty acids. Why? Because they have a good anti-inflammatory effect, which has been shown in several trials. And they also act on the muscle protein synthesis by activating the mTOR signaling pathway. So this is one effect by which they possibly can overcome the anabolic resistance. And in this study, the graph shown here, it was observed that about 2 grams per day supplementation of omega-3 fatty acids, along with strength training, had better muscle strength and physical function as compared to individuals who had strength training alone. Now, coming on to the role of exercise. Exercise has a very important role, particularly in management and prevention of sarcopenia. So exercise, we all know, it not only improves the cardiovascular or respiratory function, it also improves the muscle strength, impacts endurance. Now, among the various exercises, that is aerobic, resistance, or combined, which one is better? Aerobic exercise, it has improvement in various parameters such as insulin sensitivity, improved mitochondrial density, improved cardiorespiratory function, but it does not have any significant effect on the muscle fiber size, which is the important abnormality in patients with diabetes and sarcopenia. On the other hand, resistance exercise has improves muscle mass, strength, and body composition, and also leads to improvement in the insulin sensitivity and other parameters which are affected by the aerobic exercise. Therefore, resistance exercise will have a more important role in individuals with sarcopenia. So this was a study where the comparison of aerobic resistance and combined exercise was performed to see the change in the physical performance as well as the measures in of body composition and bone mineral density over a period of 6 months. And what we see here is that the maximum change in the physical performance, of course, was seen in the combination group. But if we see the change in the bone mineral density at the hip and the decrease in the muscle mass by the change in the muscle mass, that is decrease in the muscle mass, it was the least with the resistance group. And it has to be noted that maximal increase in the strength was seen in the resistance exercise group. So resistance exercise, in addition to increase in the strength, has other beneficial effects also. Mind you, there was no significant difference in the weight loss which occurred amongst all the groups. So now types of resistance exercise can be it can be as simple as calisthenics done by the own body weight, or elastic resistance bands and tubing, which are becoming much more commonly, they are being used more commonly. The reason being they are portable, less expensive, they are not gravity dependent, they are safe, and once a patient is trained, can continue forever. Other modalities may be free weights and more complicated setups like machines, which are not easily accessible for everybody. Now, this I am showing here is few of the exercise, the clips from the videos of the resistance exercises, which have been, this video has been devised by my group, and which we are providing to the patients, and they are doing at home, and they are getting significant improvement in the parameters of muscle strength as well as the physical performance. So this is the recommendations are that it should be individualized, start with moderate, then go on to vigorous, minimum 2 days in a week, maximum 3 days. Preference, it should be a non-consecutive days per week. The gradual gradual increase in the resistance and number of repetitions should be done. Now coming on to the drugs and how do they affect sarcopenia, the anti-diabetic drugs. Metformin has been well studied, and it improves insulin sensitivity and several other functions which would be helpful in improving sarcopenia. Same thing with thiazolidinediones. They also reduce insulin resistance and may improve the fatty acid metabolism. However, weight gain with thiazolidinediones may be one issue which we are not one would not like to have. Now, incretin-based therapies, they are also shown to be beneficial in attenuating decline. GLP-1 agonists, they not only cause weight loss, but also they are helpful, particularly liraglutide has been studied in preservation of lean mass. So the less extent of lean mass is lost due to weight loss. Now, the problem lies in sulfonylureas because the available data shows that it can lead to beta cell apoptosis and decrease the beta cell mass. And then this will also be affecting the muscles to some extent. SGLT2 inhibitors, great drugs, studied for various, various beneficial effects, cardiac, renal, but when it comes to the effect on the muscle, there is very limited data, but some limited data is showing some concern that they may induce diabetes-associated sarcopenia, as well as may reduce the muscle uptake of glucose and amino acids and promote proteinolysis. However, this further needs to be investigated in greater detail. Pharmacological management, there's no specific drug for sarcopenia in diabetes. Right, testosterone has been used particularly in the presence of hypogonadism. Testosterone or testosterone analogs have been used, they have been shown to improve the muscle strength and possibly muscle mass, but their use is relatively limited because of their adverse effects in both men and women. Now, to overcome this, selective androgen receptor modulators are being tried, and several of these drugs are under investigation. Now, other drugs such as myostatin inhibitors and others, they are still in experimental stage and we are yet to see the light of the day. There's a lot of time in that. So,
Dr.
in
Naval,
summary,
yeah,
yeah,
just
this is
going
my
to,
last slide.
yeah, thank you.
Yeah. So, in summary, sarcopenia and diabetes have a bidirectional relationship, one increasing or exacerbating the other. And this occurs even in the younger age group. We don't have to be worried only in the older age group. Now, the insulin resistance, anabolic resistance, and inflammation and advanced glycation end products, these are the main mechanisms. Now, apart from nutrition, good intake of protein of high quality, evenly distributed throughout the meals, and along with supplementation, maybe with the branched amino acids and vitamin D may be helpful. And individualized multi-component exercise program with emphasis particularly on resistance exercise is very important to manage sarcopenia in patients with diabetes. And while choosing the anti-diabetic therapy, one has to give some consideration to how it is going to affect our muscle health. So with that, I want to end my presentation. And this is just our group, which is at AIMS, which is working actively on the various aspects of this. Thank you very much.
Thank you, Dr. Naval. That was very informative, very crisp, and very comprehensive as well. Uh, I'll just ask one question. Those
Yeah.
can take one question only. So, as you said, vegetarian diet, vegetarian protein has less leucine and essential amino acids. But what do we do? Because most of our patients are vegetarians. So
Yeah.
how could we ensure that we can give them a healthy diet, healthy protein, being vegetarian as they are?
I think in the vegetarians, we can what we can do in them is we can have add protein supplements, particularly whey protein supplement that can be added to them, and I think that should not be a big problem because see among the vegetarian proteins, as I showed, maize is the one which is relatively decent ratio of essential amino acids to leucine, but the use of maize in our population is not that much. So supplementing could be a useful idea in vegetarians particularly.
Thank you, Dr. Naval. That was very good, and thank you very much. Move on to the next talk by Dr. Amrita Ghosh. Dr. Amrita Ghosh is a consultant at Fortis CDoc Hospital in New Delhi, and she has been the organizing secretary of various editions of this symposium, and this time also. And she has a special interest in mobile and app-based diabetes management, insulin pump, and type 1 diabetes. So she'll be speaking on continuous glucose monitoring, evidence, and recent advances.
Thank you, Dr. Ritesh. And I hope I'm audible and my slide is visible. So without wasting much time, I will start. So good evening, everyone. And my topic for today is continuous glucose monitoring, evidence and recent advances. And in next couple of slides, I will take you through it. So just a question to all of you. Are all A1C equal? So I'll present three cases in front of you. First is a patient 55-year-old man with type 2 diabetes for 5 years on oral hypoglycemic agents and his A1C is 9%. Second patient is 15 years old girl with 5 years of type 1 diabetes and she is on a mixture of NPH and regular insulin and again her HbA1c is 9%. Third is a young man of 24 years old with 5 years of type 1 diabetes and the patient is on insulin pump and his A1C is also 9%. So do you think that all these A1C like 9%, their glycemic excursions and highs and lows are similar? So I will explain it to you in couple of slides. So how do you assess glycemic control? You either tell your patient to check fasting blood glucose or postprandial blood glucose or HbA1c. So in but all these parameters have one major flaw, that is they do not assess the term called as glycemic variability. So what is glycemic variability? Basically it is a degree to which a patient's blood glucose fluctuate between highs and lows. It is an intraday highs and lows excursion which a patient's blood sugar does, like just like a roller coaster ride here. So why is glycemic variability so important? Studies have shown that glycemic variability is directly linked towards the diabetes complication, may it be macro or micro. So you must all know about this trial, DCCT, and in this, patients with type 1 diabetes who received targeted intensive insulin therapy, they experienced delayed onset and slowed progression of microvascular complication. On the other hand, other patients who were randomized to receive conventional insulin treatment did not exhibit a reduction in the risk of progression of microvascular disease, despite, please mind my word, despite having HbA1c values comparable to those in the intensive group. And why is the difference? The difference is because of this term called as glycemic variability. Why is glycemic variability so important? It is an independent risk factors for diabetes complication, as I've already told. But what happens that is when the elevated glycemic variability is there, it leads to oxidative stress, and this oxidative stress leads to endothelial dysfunction, carotid intima media thickening, blood coagulation activation, and in turn all these parameters leads to diabetes complication, may it be macro or micro. Moving on to the effect of glycemic variability on hypoglycemic episodes. So there are published studies which have demonstrated that hypoglycemia along with glycemic variation can influence the survival rate and progression of diabetes complication in patients who are admitted in the ICUs for clinical condition apart from diabetes. So here you can see in this, there were two group of patient. One was non-diabetes patient, another one was diabetes. Here you can see the red bar is the bar which tells us the most amount of coefficient of variate, that is it calculates the glycemic variability. More the glycemic variability leads to more mortality in this kind of patient, and even in non-diabetes. So there was one more study done from South India which contributed normative data of glycemic variations, glycemic variability, and showed it was linked to the standard deviation to higher A1C values, and suggested possible utility of standard deviation in predicting risk of hypoglycemia. So glycemic variability and quality of life are two components of the glycemic pentad. So it was seen in many studies that frequent fluctuation in blood glucose with hypoglycemia and glycemic excursion affects individuals' mood changes with more diabetic complication, depression, and poor quality of life. And here you will agree with me, those patients who are coming to your OPD with tremendous highs and very terrible lows, they are more worried, and they're more scared about their diabetes progression. And higher glycemic variability was found to be associated with low quality of life than HbA1c and 24 hours average blood glucose. So nowadays we are hearing about a term called as time in range. So what is time in range metrics? Basically it provides more actionable information than A1C alone. So it includes three components. One is time above the target glucose range. Second component is the percentage of reading and time per day within target glucose range. And the third component is time below target glucose range. So here you can see in this cartoon here, one HbA1c is not HbA1c of 7%, but all the HbA1c of 7% has different kind of graphs, and only the number 3 graph, which is done in green, is 100% time in range. So we want our patients not to have highs and not to have too many lows. So what do? The primary goal for effective and safe glucose control is we need to increase the time in range, the green section, we need to increase that, and we need to reduce the time below range. So how do you measure this? So these were the time in range targets. So for type 1 and type 2, we want the time in range target, the target is 70 to 180 mg per deciliter. We want it to be more than 70%. And the time above range, which is more than 180, we want to be less than 25%. And we want severe hypoglycemia less than 1%, and hypoglycemia corresponding to less than 70 milligram per deciliter less than 4%. And when we come to elderly, you can see there is a little bit shift here. We want the target in range, which is 70 to 180, to be more than 50%, and we are a little bit lenient here, so that more than 180 is like somewhere around less than 50%. And here we are very cautious with elderly, we want the target below range should be less than 1%. And with the pregnancy, we want the target in range should be more. You can see the greener part is the bar has the more greener part. So what are the ways of measuring target time in range? Either you ask your patient to check their sugars by usage of the glucose meter, say about 7 to 8 different times of the day, like we ask someone to do it, or you can use a continuous glucose monitoring system. So what is a CGMS? Basically, it measures glucose in interstitial fluid by the glucose oxidase method, and it provides a 24 hours glycemic profile, including information on glucose trend and fluctuation. Um, and the component of CGMS is basically it has a disposable sensor which is inserted to the subcutaneous tissue, usually abdomen or arm, a transmitter and a receiver. A receiver can be an insulin pump or a smartphone, smartwatch, or handheld device. So, talking about the types of CGMS, there are real-time CGMS, retrospective CGMS, and intermittently scan. So, I'll be dealing with one by one. So real-time CGMS, here as you can see, this is unmasked and personal, used by the patient. Examples are like Guardian Connect or by Medtronic or G5 by Dexcom. It provides real-time assessment to glucose level. Okay, here you can see in this photograph, this is attached on the subcutaneous tissue here. This is the sensor, and it gives directly the information to the mobile. And here you can see the number, and here you can see a small arrow which says it's going up. That means it is giving the trend that within next hour the blood sugar will go up. This gives alerts for impending trends like hypo or hyper, and it has a lag time of almost around 7 to 15 minutes because there's a lag time which happens between the interstitial fluid and the capillary blood glucose. This real-time CGMS can communicate with the pump, and it will be used as a sensor augmented insulin pump. Retrospective CGMS. So this is basically a professional model. The doctor has it in his chamber and it is given to the patient. The patient doesn't know what's happening for him for a given period of time. So when the patient comes back, the doctor downloads it and gets a chart something like this. Here you can see different colors for different days. There's a hypo, there's a hyper. It requires a daily calibration from a patient's end, and the corrective measures can be done by the doctor later, not at the real time. Moving on to the intermittently scanned CGMS, which is Freestyle Libre Flash Monitor. This system has only two components. One here, which is worn on the arm. This is the combined glucose sensor and transmitter. And here you can see a separate touch screen reader. The patient has to just scan it over the sensor, and you get a report something like this. We'll be talking about the report later on, and it doesn't require any calibration, and it is worn for a period of 14 days. So what evidence do we have for CGMS? Talking about type 1 diabetes, this trial called as IMPACT trial, it had 241 adults with type 1 diabetes with an HbA1c less than or equal to 7%. And these people were given flash glucose monitor for 6 months, and they were seen versus SMBG, and it was seen, and 68% of the patients were treated with multiple daily injections, and out of that 32% were having insulin pump. It was seen in this study there was a reduction in hypoglycemia. The total time in hypoglycemia was reduced by 38%, and time in nocturnal hypoglycemia was reduced by 40%, and time in severe hypoglycemia was reduced in 50%. And you will all agree with me, in type 1 diabetes, the whole family is worried about hypoglycemia. Moving on to Another study of CGMS in type 1 diabetes, which was STAR3 study. This was the largest study till date done on CGMS. So 485 adults and children with A1C of 7.4 to 9.5% were randomized. They were on sensor augmented pump therapy versus multiple daily injections per day. It was seen in this study that the sensor augmented pump therapy resulted in a better A1C reduction between the group, and the difference was 0.6%. And the frequency of sensor usage, as you can see here, the more the frequency, greater is the HbA1c reduction. That means the more the patient uses the sensor, the patient is more aware about themselves and their sugars and their lows, and they do corrective measures more. So, evidence of CGMS in type 2 diabetes.
Hello, Dr. Amrita. Sorry, could you finish in 2 minutes, please? Thank you.
Yeah. So, randomized study to evaluate RT-CGM was done. Then the mean A1C was 8.5 using multiple daily injection on over the 24 week period. It was seen that HbA1c was decreased from 7.7% in the CGMS group and compared to 8% with the mean in the MDI group. Another study which was done with flash glucose monitor, it was seen more the number of scans, like 3.5, and the difference between was 3.5 to 38.5 scans per day. More the number of scan, more the time in range which was achieved by this patient. So ADA 2020 recommendation recommends that adults with type 1 diabetes, adult with type 2, children, adults, and pregnant should use RT-CGM or intermittently scanned CGM. So what kind of patients will you choose? You choose type 1 diabetes patient not meeting HbA1c target or having recurrent ketoacidosis. You will choose a patient who's having repeated hypoglycemia or having hypoglycemic unawareness. You will have a patient who will require better glycemic control while avoiding hypoglycemia, or before or during pregnancy, need for improving brittle diabetes. There are some limitations for CGMS: limited sources, less motivated patient, cost, possible interference with molecules like acetaminophen, ascorbic acid, and salicylic acid. It cannot be worn while doing MRI, and there, as I already told, there's a lead and lag of 7 to 10 minutes. Moving on to recent advances, this is the newest edition of CGMS in India, which is available. We have been using Freestyle Libre Pro, which was basically for physician. This is a patient model. It has a sensor and a reader, and it is attached to the smartphone. Here you can see the number is reflected, and there's a trend again. So the patient can scan and see the amount, what is the blood sugar, and do corrective measures to it. So this is an ambulatory glucose profile which comes as a report. Here you can see that this is the average glucose and glucose management indicators. So it also gives a time in range, and it gives a glucose profile, and daily profile is given, and you can correct, the patient can work on it, and the physician together can work on it to see where the patient is going into hypos and hypers. And basically the usage of time in range is we need to minimize hypoglycemia and targeting by less than 4%. The future of CGMS is the Everson XL CGM system, which consists of an 180-day implantable sensor. Here you can see a small sensor. This is implanted under the skin, and it uses fluorescent technology to send measures via a rechargeable transmitter, which reads above the skin to a smartphone app. So this is for 6 months, the patient doesn't have to worry about it. But again, after 6 months, the patient has to do it. So in summary, I would like to say that the sensor-based glucose monitoring overcomes limitation associated with A1C test while providing actionable insights for improving glycemic control and eventually reducing glycemic complication. 2020 ADA guidelines have already recommended that A1C in conjunction with continuous glucose monitoring system should be used. A growing body of clinical evidence, as I just showed, supports the use of sensor-based monitoring, and key benefits basically includes improving time in range, improving HbA1c, decreasing hypoglycemia, decreasing hospitalization, decreasing work absenteeism, and improving quality of life. And when you need to start getting patients started on this appropriate monitoring system, you have to get proper collaboration and shared decision making which is done with your team and your patient. Thank you so much for this opportunity, and I'm ready to take some question.
Thank you, Amrita. We are already, delayed as far as our schedule is concerned. So we will possibly keep your questions for some other time, maybe late in the evening or maybe tomorrow.
Sure, sir. Okay.
Let's go to the next session, and that is Ritesh Gupta will be speaking on SGLT inhibitors and heart failure insights from DAPA HF. Ritesh.
Thank you, sir. I'll speak on SGLT2 inhibitors and heart failure. So why are we talking about heart failure? And we know it's a very important morbidity. It increases mortality after discharge from hospital. This is one study which says that in the patients who's hospitalized for heart failure, the mortality goes up in the next 5 years, as high as 70 to 75%. And as far as diabetes is concerned, there was a registry from United States, GET with the guidelines heart failure registry, of more than 360,000 patients of 360,000 heart failure hospitalizations, out of which about 44% had diabetes. So diabetes clearly is a very important comorbidity as far as heart failure is concerned. And also conversely, diabetes associated with a very high risk of development of heart failure, so up to 3 to 5 times more fold risk of heart failure than people who do not have diabetes. And also this heart failure often requires hospitalization. But why do diabetics develop heart failure? Of course, we all know that there is ischemic cardiomyopathy, there is coronary artery disease, but then a whole lot of people have heart failure with preserved ejection fraction, and the reasons postulated for that are whether there is impaired cardiac metabolism and substrate utilization, there may be altered insulin signaling, or advanced glycation end products could be deposited in the cardiac muscle, and this is how heart failure could be developing. And to that end, we have so many treatments available for heart failure: diuretics, beta blockers, ACE inhibitors, ARBs, aldosterone receptor antagonists, ivabradine to some extent, then sacubitril, valsartan, and of course coronary revascularization, and then assist devices and the AICDs, etc. And many more, in fact, which are forthcoming. But despite all these advancements, it carries a very high mortality. The projected 5-year mortality is 75%, with 82% of these patients requiring hospital readmissions. So clearly there is a need to do something more, definitely for people with diabetes and also for people who do not have diabetes. So there is a large gap which needs to be filled. SGLT2 inhibitors, as we are all aware, have shown profound effects in heart failure. Irrespective of the agent used, they reduce heart failure. But why do they do so? Let's have just spend 2 minutes on that. Well, the conventional mechanisms are that they lower glucose, they lower blood pressure, there is diuresis, natriuresis, weight loss. But are these conventional mechanisms enough to explain their effects, observed effects on heart failure? Blood glucose lowering is probably unlikely to account for that to a great degree, because CV benefits often start very early. And the HbA1c differences between treatment and placebo arms in all these trials have been very small, and the baseline HbA1c does not correlate with CV outcomes. And benefits then now have been seen in individuals without diabetes also. Blood pressure lowering is also very modest and probably insufficient to fully explain CV benefits. Diuretic effects, but then the same effects are not seen with thiazides and loop diuretics, though it is postulated that these drugs cause preferential reduction in interstitial fluid rather than intravascular compartment, so there may be less sympathetic stimulation and consequently cardiac benefit. And weight loss again is modest. It's not a very great weight loss, and that also diminishes with time. And similar other weight loss strategies do not show similar CV benefits. So there is clearly some other mechanism which is working. We don't know what it is. One postulated mechanism is that there is a shift in body metabolism to produce ketones, which are a more energy efficient substrate than fatty acids or glucose. But then again, the ketone levels generated from SGLT2 inhibition are actually very modest. So they may not be shifting cardiac fuel metabolism to a great degree. Then there is reduction in inflammation. There is something called NLRP3 inflammasome in the genome, and which is responsible for inflammation in the heart. And SGLT2 inhibitors, either directly or through formation of ketones, could inhibit this and could be anti-inflammatory. Then there is reduced sympathetic nervous system activation, resulting in reduced blood pressure and heart rate. there is effect on cardiac remodeling. There are many studies, especially animal studies, which have shown that they inhibit various pathways and involved in cardiac hypertrophy. However, most of these studies are in animals, and this has not yet been corroborated in human studies. In fact, one study which studied the dapagliflozin on left ventricular and systolic volume, there was no difference, and other parameters of left ventricular modeling were also no different in people who received this drug. So we don't really know whether this is an important mechanism. Then there is a very often well talked about mechanism called inhibition of cardiac sodium hydrogen exchanger, which is activated in cardiac stress and leads to adverse cardiac remodeling and also ischemia reperfusion injury. And SGLT2 inhibitors inhibit that and thereby correct this abnormality. Then increased erythropoietin, which is seen with these drugs, can also lead to increased oxygenation, increased oxygen delivery, reduced left ventricular mass. So that could be one contributing mechanism. Then there is reduced oxidative stress. There are studies. Again, these are all experimental animal studies from which we have this data. There is improvement in vascular function, improved endothelial function in one study compared to metformin, and that could be contributing to it. But one very recent mechanism which has been published very recently is that these drugs could be causing what is called fasting mimicry. By urinary glycosuria, urinary calorie loss, they are mimicking fasting, and that is leading to activation of AMPK and activation of SIRT1, which cause anti-inflammatory and other effects, and that could be one mechanism which is interesting. So with that background, let us see what we have in the current DAPA-HF trial. Well, DAPA-HF assessed dapagliflozin in patients with chronic heart failure with reduced ejection fraction with or without type 2 diabetes. And these were more than 4,700 patients, adults, with or without type 2 diabetes. And they all had symptomatic heart failure, and LV ejection fraction was 40% or less within last 12 months, and they all had elevated NT-proBNP. And EGFR was 30 ml per minute. And the primary endpoint was time to first occurrence of any of the components of the composite CV death or hospitalization for heart failure or an urgent heart failure visit. And then there were several secondary endpoints. So this is what was seen, that the primary endpoint was significantly better with dapagliflozin. There was a 26% relative risk reduction in the primary endpoint. And if you see the components of primary endpoint, similar reduction was seen in worsening heart failure event or in CV death. And if we analyze it according to pre-specified subgroups, there was no difference whether we consider diabetes or baseline EGFR or NYHA class or LVEF or age or sex or race, geographic region, etc. So this was a consistent effect observed all subgroups. And secondary endpoint, which was heart failure or CV death, was also significantly lower with dapagliflozin. And health status assessed by change from baseline in KCCQ-TSS, that is Kansas City Cardiomyopathy Questionnaire, that was also assessed, and that was also seen much better in patients on
he knows what.
dapagliflozin.
When you put a speaker, why is not going?
Hello. Yeah. Secondary endpoint was worsening renal function, and this was also much better with dapagliflozin. All-cause death was also better with dapagliflozin. And interestingly, the change in NT-proBNP was better. There was a significant reduction in NT-proBNP with dapagliflozin. Now, if we analyze the primary outcome by diabetes status, because about 45% patients had diabetes and 55% did not have diabetes, so whether the patients had diabetes or did not have diabetes, the effect was similar. And in fact, even in those who did not have diabetes, those who were normoglycemic or those who had pre-diabetes, all groups showed significant reduction in primary outcome, and there was no significant difference. Interestingly, the incidence of new onset type 2 diabetes in the population with type 2 diabetes at baseline, without type 2 diabetes at baseline, was lower with dapagliflozin. There was a 32% relative risk reduction in patients developing new onset type 2 diabetes, which is significant. And safety outcomes were all acceptable, and there was no difference in safety outcomes whether the patients had diabetes or did not have diabetes. Now, the similar trial was Emperor Reduced trial, which studied empagliflozin in NYHA class 2 to 4 heart failure with a reduced ejection fraction, and this also included patients with elevated NT-proBNP, but this included patients who had EGFR of more than 20 ml per minute compared to, and in contrast to 30 ml per minute in DAPA-HF. And about 38 months follow-up was there, and about 3,730 patients with the sample size. And the primary endpoint in DAPA-HF and in Emperor Reduced was almost similar. Hazard ratio is similar, and most of the other endpoints was also similar, except that the onset of new diabetes was not observed in patients who were on empagliflozin, while in dapagliflozin there was a significant reduction in that. Now, coming to my last slide, this is my last slide. So dapagliflozin in heart failure has been studied now with the DAPA-HF trial. We have seen that apart from patients with diabetes, dapagliflozin has been shown to be to reduce cardiac mortality and hospitalization for heart failure even in people who do not have diabetes, and that is why it has been recommended by several societies, first by Canadian Cardiovascular Society, then European Society of Cardiology, US FDA, and also DCGI in India has also approved it to treat patients in heart failure with or without diabetes. With that, I'll finish. I'll be happy to take any questions.
Ritesh, excellent. You finished in 10, 12 minutes. That's wonderful. We saved 3 minutes. So I have time to ask you one question. You have very nicely shown that dapagliflozin reduced new onset diabetes. So suppose we use dapagliflozin in patients with pre-diabetes and prevent diabetes in those people who cannot exercise, who cannot diet, and who have a high body mass index. What about that?
Absolutely, sir. This is something which is promising, and it could be. I think we should have a data also for that. Off-label use is anyway being done in people who are overweight and who have a high risk of diabetes, who have pre-diabetes. It is being used. So we just need some more data, but there is really no contraindication as if the patient is tolerating it well.
And especially in Indians, where conversion from pre-diabetes to diabetes is very, very fast.
Absolutely right, sir.
Good. Thank you, Ritesh. Now you take over and continue with the next speaker.
Right, sir. I'll now invite Dr. Seema Gulati for the next session. Dr. Seema?
Share the slide, Ritesh.
Yeah, sorry, I have not unshared. I think I have unshared. Yeah, I have unshared, I think, now.
Yeah, now it's unshared.
Yeah. So Dr. Seema Gulati is the head Nutrition Research Group, Center for Nutrition and Metabolic Research, NDOC, and she's also a project research officer, a chief project officer, Diabetes Foundation India. She has worked extensively in the field of nutrition research, in interventional nutrition research. She has co-investigated more than 15 research projects, and it has worked in community as well as clinical nutrition. So over to Dr. Seema Gulati on novel dietary interventions to control postprandial hyperglycemia.
Thank you, Dr. Ritesh. So I'll be speaking on novel dietary interventions to control postprandial hyperglycemia. Loss of postprandial glucose control is first metabolic alteration in the progression of type 2 diabetes. And we know that postprandial hyperglycemia, it occurs 4 to 7 years before the fasting blood glucose levels begin to rise. And recent studies, they have shown it has been documented that the relevance of postprandial hyperglycemia, the risk factor, not only for CVD mortality, but also for all-cause mortality. And the main cause of postprandial hyperglycemia, especially in Indian setup, is the a high carbohydrate diet. We Indians, I mean, the STARS study has shown that we are consuming about 64% of carbohydrates in a meal. And this slide I have taken from 1 year's paper. Very nicely, he has shown that humans are spending half of their life in postprandial state. The postprandial state is defined as 4-hour period following ingestion of a food, and then after postprandial period, there is a post-absorptive period which lasts, say, about for 6 hours. So if a person is taking just 3 meals, breakfast, lunch, and dinner without any snacks, he's spending at least 12 hours in the postprandial state. And of course, we are taking snacks in between and at bedtime. So the real fasting state is lasting hardly for 3 to 4 hours. So there's a need to focus on postprandial hyperglycemia because most of the time we are in this state. So another paper by Monier has shown that when there's a good glycemic control, say HbA1c levels around 7.3, then the contribution of postprandial hyperglycemia is very high, say almost 70%. And as the HbA1c levels increase, or with the worsening of diabetes, the contribution of postprandial hyperglycemia decreases, and that of fasting hyperglycemia increases. So in early diabetes or in pre-diabetes, the contribution of postprandial hyperglycemia is really significant. Here, this is from Heart 2D trial, where Melsevic has taken 5 ethnic group population from India, Central Europe, West Asia, South Africa, and Canada, and their blood glucose levels were assessed at 7 time points. And post-meal, all ethnic groups showed poor glycemic control. They showed higher peaks. But if you see this dotted line, which represents Indian population, Indians showed the worst glycemic control and higher peaks at all time points. So Indians need to address postprandial hyperglycemia even more vigorously. To quote couple of studies here, in DECODE study, which analyzed 10 prospective study and showed that it is the 2-hour blood glucose levels which are more important than fasting plasma glucose when it comes to all-cause mortality or cardiovascular mortality. Similar findings were shown by, say, Chicago Heart Association study or diabetes intervention study, and also by a companion postprandial hyperglycemia study. They've all shown that it is the postprandial hyperglycemia and not the fasting plasma glucose, which is better associated with, say, myocardial infarction or CVD event or, all-cause mortality. Now we know that there is a problem of postprandial hyperglycemia and it's more rampant in Indian population. So we'll focus on dietary strategies. What can be done when it comes to diet for controlling postprandial hyperglycemia? Now, first of all, carbohydrate, we know that they are the primary dietary component which influence blood glucose levels. Woliver has shown in his study that the carbohydrate content and glycemic index together explain about 90% of the variation in the glycemic response. When we lower the carbohydrate content, then it is associated with increased lipolysis, decreased lipogenesis, decreased fatty acid concentration, and decreased storage of fat in the adipose tissue. So it is very important to limit the intake of carbohydrate if we want to control the postprandial hyperglycemia. Now, fiber, we know that when fiber is added to the diet, the glycemic response is decreased. Brens in his study has shown, when healthy subjects, when their fiber intake was increased for a week, and then their glucose was monitored using continuous glucose monitoring system, then lower peaks were reported for glucose at all time points. So fiber helps in lowering the postprandial glucose peak. When we increase the fiber in the diet, it leads to delay in starch digestion and transition of stomach contents into the duodenum, or it delays the gastric emptying. Now, coming to protein, when lean protein of high biological value is added to the diet, it again blunts the glucose response. In a study of healthy individuals, when the whey protein was added to pure glucose drink, it lowered the postprandial blood glucose area under the curve by 56%, which is very, very significant. And we had also published a study in 2017. In this study, we had given high protein diet to patients for 3 months. And then when we assessed their glycemic parameters, there was significant improvement with regard to fasting blood glucose, postprandial glucose, and HbA1c levels. So there are different food items such as vinegar, cinnamon, fish oil, olive oil, yogurt, salads, legumes, nuts. When they are mixed in the diet, they lead to improved postprandial glucose response. The postprandial glucose response is not that high when these foods are included in the diet. But now there is an emerging approach. We know that when these certain food items or when carbohydrates are decreased or protein is increased or certain food items are incorporated, there is a improved postprandial glucose response. But it was shown in 2006 that if there's a preload of a non-carbohydrate food, it leads to better glucose response. And there is almost 40% reduction in the glucose peak. Like preloading each meal with protein or fat, or simply tailoring the sequence. If there is we are served a meal and we look for where is the protein in the meal, and we take protein first and carbohydrate last. Just by tailoring the sequence, we can get improved postprandial glucose response. Wu has also shown that when 25 grams of whey protein preload is given, it shows similar effect to that of DPP-4 inhibitors, which is quite significant. How a preload of non-carbohydrate food works: when we give a preload, it helps in delaying the gastric emptying because there is a protein or a fat preload, and then there is decreased insulin clearance, so more insulin is available, and there is improved beta cell function, and there is improved incretin secretion. So this is how a preload of non-carbohydrate food benefits the postprandial glucose response. There are a couple of studies which have shown that when a soya yogurt snack is given before the meals, it can lead to reduce postprandial glucose increment as much as by 40%. And also it has been shown that when a 10 grams of fructose is given 30 minutes before a carbohydrate meal, there is a improvement in, or there is a decreased area under curve for glucose. And in a study, it was shown when almonds are given prior to the main meal, there is a postprandial glycemia decreases by as much as 15%. So taking almonds further, Jenkins has also shown that when about 30 to 90% of almonds are added to test meal, there is like 21% to 42% reduction in the postprandial glucose peak. And we had also conducted a study where we had given almonds to patients with type 2 diabetes, and the intervention was for 6 months, and we noticed that at the end of the intervention there was improved HbA1c level as well as the postprandial glucose levels. So we know that Indians, they have high magnitude of postprandial hyperglycemia owing to high carbohydrate diets, and we are at higher risk for CVD. And till now, if we look at the lifestyle approaches, mainly the approaches have focused on weight loss or improving insulin sensitivity via exercising or limiting the carbohydrate intake. But there's no such study which has focused on, say, when we give a preload of a non-carbohydrate food, then what happens? Then how it impacts the postprandial hyperglycemia. So basis this, we planned a study which is evaluation of preload of raw almonds on postprandial hyperglycemia and other metabolic responses in Asian Indians with prediabetes. So we hypothesized that if the dietary intervention with almonds is 60 grams per day, that is 20 grams before breakfast, lunch, and dinner, it will decrease the glucose and insulin excursion after meals and reduce overall hyperglycemia. So this study had 3 phases: acute, subacute, and chronic phase. So in subacute phase, what we did, we monitored the glucose levels using continuous glucose monitoring system, which Dr. Amrita has explained very nicely. So patients were coming to the facility and we put them on controlled diet. And then after a washout period, we gave them almond diet. And each time we monitored their glucose levels. So here I would like to give an example. There's a patient who is coming to the facility, say 51-year-old pre-diabetic male, who was coming with a family history of diabetes and had fasting plasma glucose, say about 102 milligrams per deciliter, and the post meal was about 158. So when we put him on controlled diet and for 3 days we had put this CGMS device, so you can see there's lots of ups and down in the blood glucose, lot of perturbations. So, and just a week later, when he was put on almond diet, then we can see the flattened curve. Now, going into the details of the report here, day wise, when he was on controlled diet, we can see higher glucose peaks post meals. But when he was put on almond diet, where almond preload was given, we can see completely flattened curve. So now these are the this is the average of, say, 60 patients that were recruited for the study, an average of 3 days glucose levels. Here, starting from midnight of one day to midnight of next day. This blue line is showing almond diet, and red is for patient on control diet. We can very clearly see at all time points, the patients on almond diet showed lower glucose response. This is very significant finding, and for all patients we could see this kind of a response. Going further, when these patients were given almonds, say for 3 months, because when they entered the chronic phase, and the same dietary regime was followed, like 20 grams of almonds prior to meals, and at the end of 3 months we assessed their blood parameters, and what we noticed that there was a significant improvement in fasting blood glucose levels in patients who were on almonds diet, and there was significant improvement in postprandial blood glucose levels as well.
Dr. Seema, you're requested to finish in 2 minutes, please.
I will do that. And similarly, there was improvement in HbA1c levels, significant improvement in HbA1c levels, and HSCRP levels also improved, but the statistical significance was not there. To sum up, Asian Indians show higher postprandial hyperglycemia in comparison to other ethnic groups. Lower carbohydrate, higher protein, and higher fat diets can help dampen the postprandial glucose spike. Emerging research shows that pre-meal ingestion of non-carbohydrate food items can help control the postprandial hyperglycemia. A preload of 20 grams of almond help lower the postprandial glucose peak and HbA1c level. Thank you.
Ritesh, permit me to ask one question before we move on to Dr. Wagner's lecture. Seema, very nice presentation. The question is from Dr. Jayant today from the United States. And he says, if you can quickly answer, not a detailed answer, what is your opinion of ketogenic diet in diabetes in Indian?
See, the ketogenic diet, it's very high fat and very high protein diet. I mean, it may produce short-term, results, but in the long run, we can expect, complications. The best way to control diabetes is, following a balanced diet routine with exercise, with resistance exercise, as Dr. Vimal has mentioned. So ketogenic diet, I personally don't think is a long-term solution. Yes, it can definitely produce short-term, it can give short-term results, but again with complications. So,
thank you, Seema. Very nice answer. And we don't know what ketogenic diet with a very high fat content causes to the liver, which are already bad in Indian population.
Right.
So thank you once again. Ritesh, please carry on.
Thank you, Dr. Seema. Now we have a special lecture by an eminent speaker, and it's a privilege to introduce Dr. Subhash Wangnu, who's a senior consultant endocrinologist and diabetologist. He is currently heading the Apollo Center for Obesity, Diabetes, and Endocrinology. He has numerous publications. He is involved in teaching and training of DNB endocrinology, and he is an excellent teacher. He has lectured in various fora. So I invite him to deliver his talk on the beta cell preservation holy grail in diabetes management. Over to Dr. Wangnu.
Thank you, Ritesh, and thank you, Anup, for inviting me in this Ahuja Bajaj Symposium, and which I always look for every year to see how it goes about it. And thanks for the scientific agenda, what we have put forward. And I'm just going to talk about the beta cell preservation, the holy grail in diabetes management, though it is a very huge subject. So I'll be in short telling you about the few bullet points and the important message which you can drive about the beta cell preservation. Before we go on to the beta cell preservation, let's talk about why do beta cells fail in type 2 diabetes. Obviously, there has to be some reason, and you can see three important modalities or the mechanistic explanation why do beta cell fail are because of the reduced beta cell number. I will tell you the mechanism is because of the beta cell dysfunction, which is progressive. And also last but not the least, the compromised identity. So this is a pictorial view of the three important aspects of beta cell failure in type 2 diabetes. Let's see what happens. By the time the type 2 diabetes develops, 40 to 50% of the beta cells are lost, with a further loss of 4 to 5% each year. In the last slide, previous slide showed you the reduced beta cell number. The beta cells are most vulnerable to apoptosis during the period of persistent hyperglycemia. That is well known. And along with that, the genetic and environmental factors are responsible for the initial low beta cell mass in diabetics. Second important is the progressive beta cell dysfunction. Because of the altered glucose metabolism, which leads to the increased oxidative stress, and also stress on the endoplasmic reticulum leads to the metabolic stress. Coming to the third and important entity called compromised identity, which says that there is a de-differentiation and the trans-differentiation into other cell type. And there was a very beautiful experiment in the mice where they have FOXO1 deficient beta cell in the mice when they induced the FOXO1 deficient. And when they subjected these mice, which were deficient in FOXO1, to high metabolic load, it causes loss of beta cell gene expression and subsequent differentiation and reprogramming, resulting in loss of beta cell function without cell death. And we know FOXO1 is an important transcription factor that plays important roles in the regulation of gluconeogenesis and glycogenolysis. That is why maybe in human also, we can presume and postulate and say that FOXO1 deficiency might be responsible in the development of the beta cell dysfunction. Now, how to assess the beta cell function? Very difficult. Predictors of beta cell functions. The gold standard still remains the clamp technique. So, which is basically a research protocol, very difficult to do. It's a time consuming and very expensive research tool of the clamp technique. But some of the surrogate markers, which we can do as an OP patients or patient basis, HOMA beta is simply can be calculated by the 20 into fasting insulin divided by fasting plasma glucose, pro-insulin to insulin ratio. Then you can do C-peptide in fasting or stimulated. You can have a pro-insulin or the C-peptide ratio. And HOMA-IR, basically, which represents the insulin resistance, is simple to calculate. Insulin multiplied by the fasting blood sugar divided by 22.5. Anybody having an HOMA-IR more than 2.5 is indicative of the insulin resistance in that patient. Many of even the research protocol people use Matsuda index, which is calculated by the formula which I have given here, and the normal value is less than 4.3. There are some other methods like Quickie, quantitative insulin sensitivity check index, and disposition index, which is again a true assessment of beta cell function, basically which is the product of insulin sensitivity and the insulin secretion, called the disposition index, refers to the insulin secretion adjusted by the insulin sensitivity and reflects true beta cell function. We had many studies from the India where they have really done in the Asians by doing the disposition index with the effect of some gliptins along with the metformin in improving the beta cell function. Now coming to the beta cell in Indians, because of high diabetes susceptibility in South Asian, it was shown because of the decreased beta cell function and impaired insulin action, we have a high diabetes susceptibility in South Asian. And the need of the hour is this: to adopt strategies in diabetes prevention must minimize loss of beta cell function. And we do have a relatively early loss of beta cell function, and that is why our population may need early use of insulin providing therapies, and the failure of metformin monotherapy is more likely in our population. Before I go to the type 2 diabetes preservation, the beta cell preservation, let me give a snapshot what is the scenario of the beta cell preservation strategies in type 1 diabetes. Though it is basically a dismal approach because of the unsuccessful trial results, but I will tell you something which has been done in the past. Antigen-specific approaches using insulin, GAD65, HSP60, unsuccessful trials. Antigen non-specific approaches using cyclosporin, BCG, anti-thymoglobulin, anti-CD3 and CD20, IL-1 antagonist, TNF-alpha blockage. And lately, the in vitro differentiation of stem cells using indolactam V, which enhances the differentiation of embryonic stem cells derived endodermal cells into PDX1, which are the expressing pancreatic progenitors, but still the differentiated cells which are produced are still inefficient and immature, and they don't last long. Now coming to the main topic of the beta cell preservation in type 2 diabetes. We have a host of modalities, including lifestyle modification, use of many oral anti-diabetic drugs in the horizon, which can be used for the beta cell preservation, among them metformin, TZDs, SGLT2 inhibitor, which was the talk recent, 2 talks back, GLP-1 receptor agonist, early insulin treatment, DPP-4 inhibitors, and bariatric surgery. My little focus will be on the DPP-4 inhibitors, but I'll be touching in short about all other modalities. Coming to the diet and exercise, lot has been taught in the diet and exercise, but a word about the direct trial where very low caloric diet has been found to achieve remission in about 65% of the participants to a non-diabetic state. And these patients were given 825 to 850 kilocalories per day for 3 months, which was followed by stepped food reintroduction after 3 months and was followed by structured supportive dietary treatment plan. So this is one of the current evidence about the role of diet and exercise in beta cell preservation. A word about the metformin. Way back in 2001, the Chinese prevention study recorded 65% reduction in the progression of IGT to type 2 diabetes when the patients were put on metformin. And in parallel to the diabetes prevention study, the study by Dr. Ramchandran, Indian Diabetes Prevention Program, had shown 26% reduction in the cumulative incidence of diabetes in patients on metformin. Now, what are the mechanisms behind the use of metformin? The long-term clinically relevant effect of metformin is to enhance hepatic insulin sensitivity, which is mediated by AMPK, and AMPK acutely inhibits fat synthesis and activates fat oxidation in the liver. Metformin is also known to alter the intestinal microbiome, and people are talking a lot about the microbiota and diabetes, and metformin also acts on the gut to increase GLP-1. This is another modality. TGDs, we know the TGD has been used for many years, and we know that TGD upregulates expression of genes which are involved in beta cell glucose sensing, including GLUT2 and glucokinase. It leads to increased beta cell sensitivity to glucose and improve insulin secreting capacity. So there was a question about the SGLT2 inhibitors, about what is the mechanism. The SGLT2 inhibitors exert protective effects on the beta cell function and mass, as evidenced in studies on obese type 2 DB mass. And to extrapolate this finding, that Dr. Anup was asking whether we can give the SGLT2 to pre-diabetic patient to basically have a protective effect on the beta cell function and mass, is basically based on some of the animal studies and can be proved in human beings also, and can be a very reasonable and exciting molecules to be used for the beta cell preservation. GLP-1 receptor agonist has been known to promote insulin mRNA expression within the beta cells, leading to maintenance of intracellular insulin stores and improved beta cell secreting capacity. GLP-1 receptor agonist also upregulates the biosynthesis of glucokinase and GLUT2, improving capacity of the beta cell to sense and respond to the glucose. Early insulin treatment, a word about, there was a study where 2 weeks intervention with the continuous subcutaneous insulin infusion, or MDI, achieved normoglycemia in 95 to 97% of the newly diagnosed type 2 diabetes, which was maintained for 1 year, and 44 to 50% of the individual. And the predictors of the response were high BMI, low fasting plasma glucose at baseline, and short duration of diabetes. Now, today I'll be having some focus on DPP4, because we know that DPP4 inhibitors enhances beta cell proliferation, survival, and differentiation. It increases insulin secretion, insulin gene expression, and expression of key beta cell transcription factor such as PDX1. And there has been study, and these studies have been published in our Indian Journal of Endocrinology and Metabolism, and also in the diabetes meta-analysis, where they have shown that the vildagliptin in particular reduces the HOMA beta and significantly improve HOMA beta, which is shown here, while there was no significant impact on the HOMA IR. And another study which has shown 1 year treatment of vildagliptin on the beta cell secretory capacity, and we have seen that vildagliptin increased the disposition index, which I have shown you earlier, after 52 weeks of treatment with the vildagliptin. Effects were not sustained following the 12 weeks washout period. That means you have to continue it. And what the recent update EASD 2020 says, the results of the verified trial, everybody knows that annual change in beta cell function, which was evaluated in the verified trial in 447 patients in the early combination and the initial monotherapy group, the median time to loss of glycemic control among these individuals was 61 versus 36 months as controlled to the monotherapy group. So it is very clear-cut message. The early combination treatment vildagliptin and metformin patient with newly diagnosed type 2 diabetes showed improvement in the beta cell function compared with metformin therapy. I think this will be my last slide because I already finished 12-14 minutes. A word about the bariatric surgery. We have seen the postprandial GLP-1 secretion is substantially and durably increased early only after RYGB as compared to other bariatric procedure, even before significant weight loss has occurred. And if you see the recent ACS Bariatric Surgery Center Network prospective observation study, we have shown the 83% of resolution of diabetes at years. These are some of the methodology models for beta cell preservation. Hope I covered them all because of the paucity of time. I could not detail each and every with some clinical trials, which were beyond the scope of this presentation. And I thank you very much for your time and kind listening.
Thank you, Dr. Wangnu. That was very concise, and you have covered a lot of concepts, lot of modalities for beta cell preservation, and you have kept the time also. Thank you so much, sir. We have a quiz now.
Let me thank Dr. Wagnu and congratulate him for wonderful presentation. Thank you, sir.
Thank you, Anup. My pleasure.
Yeah. Thank you, sir. Okay, now we have a quiz, which will be in two parts. There will be part 1 today and part 2 tomorrow. So we'll have two questions which will be projected on the screen, and there'll be 4 options to each of them, and you'll have to click on the correct option. So can we have the quiz, please?
Mr. Darshan?
Mr. Darshan, can we have the quiz, please?
Yes, sir. He started on delegate site.
No, can I? So can I see that? No.
No, sir. Only delegate can see.
Okay. Okay. Okay, the first question is, what is the percentage content of monounsaturated fatty acids in olive oil? And the options are 50%, 90%, 30%, and 70%. Mr. Darshan, please let me know when the time is up for the first.
Yes, sir. Yes, sir.
Do we allow 30 seconds, sir, for the quiz?
Yes, about 30 seconds, yeah.
Darshan, what about the quiz now?
Yes. Yes, sir. First question is over.
Is it over? Time is up?
The second question.
Okay, can we have the second question now?
You can read out the second question.
Yeah, the second question is, which of the following may be associated with hypoglycemia in patients taking insulin or sulfonylureas? And the options are A, imatinib, B, gabapentin, C, lithium, and D, ranitidine. So again, you have 30 seconds to answer.
Darshan, is it on?
Yes, sir. It's activated.
LS, when it's over.
Okay, is it done? Darshan?
Yes, sir.
Right. So the answer to the first question was, we'll announce the winners in after maybe another talk. But I can give the answers. The answer to the first question was the percentage content of monounsaturated fatty acids in olive oil is 70%, and it's a high MUFA oil, and as we know, and it's about 70%. And there are other high MUFA oils like mustard, canola, and almonds, and other things. The second question was which could be associated with hypoglycemia. Now, the correct answer is imatinib. Imatinib is a tyrosine kinase inhibitor used in cancer therapy, and many tyrosine kinase inhibitors have been shown to result in hypoglycemia or in reduction in insulin requirement because of various effects. Some postulated effects are they increase GLUT2 expression in beta cells, etc. So one has to keep that in mind once someone is on this drug. Thank you, and we will be announcing the winners after 1 or 2 talks very shortly. With that, we proceed with the next session, and the next session for the next session I invite Dr. Avdesh Kumar Singh, who is a senior consultant endocrinologist from Kolkata. He has numerous publications. He has more than 100 publications and meta-analyses and reviews published. He has contributed several chapters to several books, and he has been awarded multiple awards. And he'll be speaking today on role of anti-diabetic drugs in COVID-19, lessons learned so far. Over to Dr. Singh, please.
ये वहाँ पे हो रहा था, पोल पे आ रहा था, मैं डॉक्टर नितेश को वैसे दिखाया, वहाँ पे पोल है, पोल को करेंगे तो आएगा, हमको नहीं, तो फिर दोनों साथ-साथ रख कर करना चाहिए, हमको वैसे कर दिया, पता नहीं था ना इससे होगा.
Dr. Gupta, can you hear me? Hello.
Can hear you, Dr. Singh. Yeah, please
Okay.
go on. Yeah.
Okay, yeah. Thank you, Professor Misra, Dr. Gupta, and entire team for having me for this prestigious Dr. Ahuja Bajaj Symposium. I was the part of this meeting earlier. Somehow I got missed in between. Nevertheless, it's always a pleasure to be with all learned colleagues right now here. My job is to take you through in next 15 minutes to talk on what has happened with regards to the anti-diabetes drug in the space of COVID-19. Before I start, let me confess that this space is pretty dynamic. What we knew today, you might, go for unlearning tomorrow, or, because this is how this space is moving right now across the world. Now, when you come to anti-diabetic drugs in COVID-19, I would like to show you this paper which was published very early during the March in Diabetes Research and Clinical Practice from our colleagues from PGI Chandigarh, Rimesh and Sanjay wrote this commentary in TRCP. And at that point of time, if you all remember, there was a lot of issue being talked about any drugs which has a potential to increase ACE2 enzyme, has a potential to, allow you to contract COVID-19 more. And, on those theoretical findings, people proposed, as you can see in this particular slide, that anti-diabetes drug which per se increases ACE2, as you all know, which is the receptor for SARS-CoV-2, the person consuming these drugs may have a theoretical potential to contract COVID-19, or even if you contract COVID-19, having a severe COVID-19 may be higher if you are using those anti-diabetic drugs, which has a potential to increase ACE2. And if you look into this chart, 3 classes of anti-diabetic drug like thiazolidine, pioglitazone, GLP-1 receptor agonist, liraglutide, GLT2 inhibitors, these 3 drugs actually, reduces cardiovascular and renal diseases by just increasing ACE2. The entire insulin sensitizing mechanism of pioglitazone is based on increase in ACE2. So people suggested these 3 classes of drugs should preferably be avoided during the COVID-19 time, but with a caveat that there was no study so far conducted at that point of time during March 2020. Insulin is always a preferred drug in any emergency situation, including in ICCU, ITU setup. Metformin sulfonylurea doesn't have any direct action on ACE2, and so was the DPP-4 inhibitor. With SCQ, as you all know, the story has started from initial Chinese study followed by French, and then emergency use authorization by FDA, Trump administration, initially thought that SCQ might be a useful anti-diabetic drug, especially in Indian context, because DCGA has approved that. Now, with this theoretical assumption, again, in absence of any clinical studies, we were the first across the world. And as you can see, the entire group from the 40 CDoc led by Professor Misra and Dr. Gupta. And we wrote initial recommendation during COVID-19, again, with a caveat. At that point of time, we didn't have any clinical study. But by knowing the mechanism of anti-diabetic drugs and with the anticipation that two class of drugs, especially metformin and SGLT2 inhibitor, which is often associated with either lactic acidosis with metformin or euglycemic diabetic ketoacidosis with SGLT2, with this anticipated fear of acidosis, we proposed not to use metformin and SGLT2 inhibitor in patients, those who are hospitalized, thereby meaning that we propose not to use this two class of drug in patients who are having severe COVID-19. But please remember, we didn't recommend not to use these drugs in patients who had mild to moderate COVID-19. We only recommended in a hospitalized patient just with the anticipation of lactic acidosis and euglycemic DKA. Followed by our, expert opinion or a statement, the international authorities and people across the world met together and came up with personal opinion in Lancet Diabetes and Endocrinology. As you can see, there are 17 authors in this particular paper. They went further ahead and suggested that let's stop metformin and SGLT2 inhibitor. The difference between our recommendation and the international body's recommendation was that we propose stopping metformin and SGLT2 only in patients, those who are hospitalized or maybe having a severe COVID-19. However, the international group recommended that let's stop metformin and SGLT2 in every case. Again, with a caveat, these were early paper, came in April, no study so far with anti-diabetes drug and COVID-19. So all, these opinions were just assumptions. The third guideline came from the UK people, came in diabetic medicine this is a UK position, a statement. They were pretty similar to us and proposed not to use, again, metformin and SGLT2 in patients with severe COVID-19. So these are the three, guidelines across the world which thought that perhaps metformin and SGLT2 are not a great drug, especially in patients with severe COVID-19. But as I said, with a caveat in absence of any clinical study. This led us to look for, is there any recommendation or a study in the past, during the past SARS infections like SARS-1 or during the MERS or during any acute viral illness. So we reviewed the literature and we published this paper somewhere near the June, whether anti-diabetic drug has any wrong signals in acute viral illness, respiratory diseases, or in previous SARS infections like SARS-CoV-1 or MERS. And you would be surprised to find that we didn't find any evidence so far in the past which suggested that there is a clean recommendation to suggest or to stop these anti-diabetic drugs, maybe except in a situation when patients are very critical and you may not be requiring oral drugs. They, of course, needs to be put on insulin infusion. So we propose that we don't have any data which suggests to stop any anti-diabetic drugs in patients with mild to moderate COVID-19. This was a huge paper, and this is the conclusion on your right-hand side, and we recommended that we don't have any data which suggests to stop these anti-diabetic drugs in mild to moderate COVID-19. Now, this led us to really looking forward to all those anti-diabetic drugs and what has happened since March to now ending November 2020. So we looked back into all the papers with anti-diabetic drug so far done in COVID-19. Now, I will primarily focus on metformin and DPP-4 today because that's what the maximal data we have generated so far. I will finish by saying about SGLT2 inhibitor that there is one double-blind randomized controlled trial which is right now undergoing. A huge number of patients, 900 patients, and called DARE 19 being conducted with dapagliflozin. This trial is under progress, and I can tell you that this trial is supposed to be published in December 2020, so from 1 month from now, but I just checked back into the current status. This trial is still recruiting, and I believe this would be delayed. Now, what is interesting to note that this trial was conducted since April 2020, and there is a data safety monitoring board which is looking into the safety of dapagliflozin in patients with COVID-19. Let me also remind you that DARE 19, is being done with dapagliflozin, but it's not only recruiting patients with diabetes, it's also recruiting patients without diabetes, with cardiovascular disease, with chronic kidney disease. They are all, highly cardiorenal sick patients, those who have been recruited in this particular trial with or without diabetes. And yet, since April 2020 to November 2020, as you can appreciate, 5-6 months has passed now, but there is no wrong signal so far from the Data Safety Monitoring Board. This suggests that this trial is, going pretty well right now. But we have to wait for the final results with SGLT2. We don't have any other data so far with SGLT2. Neither we have any data with GLP-1 receptor agonist or sulfonylurea or pioglitazone. So let's focus here on metformin and DPP-4 inhibitor for the moment. Now the story goes back to this famous, retrospective dedicated diabetes study called Coronado. I would like to remind you that Coronado has got actually 2 papers. The one was published, earlier in Diabetologia, which is in front of you, which is an interim report. This is not the final report. Final report is yet to come, and I will show you those data, which is coming in Lancet very soon. So in the initial interim report, that Coronado was planned for a 28 days trial with a primary outcome of looking into intubation or all-cause death. The secondary outcome was death at day 28. So, in hurry, they published an interim report. Now, when you look into this interim data report with different anti-diabetes drugs, it is fascinating to see that none of the anti-diabetes drugs so far has done anything wrong in this particular large 1,317 patients Coronado's interim report. Interestingly, if you see the secondary outcome, there was first time, some signal which suggested that the metformin user COVID-19 patients with diabetes had somehow better outcome, less mortality. You can see 41% reduction in death in metformin arm, as opposed to 71% increase in those receiving insulin, during admission with COVID-19 in this 20 French, centers study called Coronado. However, this is a univariate analysis, and when it was adjusted for multiple variables, they came to the conclusion neither anti-diabetic drug, is supposed to have any wrong signals in patients with COVID-19. However, this led us up, imprinting that somewhere metformin is doing good, although in the multivariable analysis, this lost its significance. Even metformin lost its significance, and there was no harm so far with insulin. So this is the first interim paper. Since this paper, number of paper has published, and I will not dwell into detail because of constraint of time, but I will show you some of the important paper which is going to be published. The next one is the final Coronado trial, and I'm presenting here with the permission of the authors, because I was the referee of this paper, which is now accepted and will soon anytime come in Lancet. This is the Coronado final study presented at day 28. Now, amazingly, in a multivariate analysis, the metformin is responsible for a 29% reduction in all-cause mortality at day 28, as you can see in this Kaplan-Meier curve, clearly suggesting that those metformin users, diabetic patients with COVID-19, had significantly less mortality compared to non-metformin users. So that's perhaps the largest and the best data which is being generated with metformin in COVID-19. Now, prior to this, the final Coronado, and I'm not going into detail, suffice to suggest that if you look back into the metformin data in previous SARS-CoV-1 or MERS infection, or for that matter in any acute viral illness, including acute exacerbation of bronchial asthma or pulmonary tuberculosis. For the lung disease, metformin was always supportive. Metformin has always a good data, typically in patients with lung disease. And if you see the COVID-19 data, which I have put you here, which is the most updated until November 6th, these all are the papers with metformin, and I have summarized in this particular table, barring one study, which actually suggested increase in severity in the metformin user. Majority of these studies suggested that metformin users had lesser mortality compared to non-metformin users. Remember, the mortality data, although these are retrospective studies, but you cannot deny the mortality benefit even in an observational study. So these data are strongly favoring that the metformin users had less mortality compared to non-metformin users. And this is a meta-analysis, of some of those papers which is recently published in Diabetes Metabolic Syndrome Clinical Research and Review, again suggesting of a significant reduction in all-cause mortality, even with adjusted odds ratio, as you can appreciate here, with a 36% reduction in all-cause mortality in metformin user compared to non-metformin user. So that's the data of metformin. The DPP-4 space is also quite fascinating, considering that DPP-4 is also considered as a co-entry receptor from some of the studies. Remember, the DPP-4 was the entry receptor for the past MERS-CoV infection, and both are brother to each other. It was thought that over the time, this COVID-2 or SARS-CoV-2 will also go through this DPP-4 enzyme as an entry receptor. And that's why the DPP-4 inhibitor came into the limelight for several reasons. Now, as I said, because DPP-4 was also found to be the co-entry receptors for SARS-CoV-2 along with ACE2 in some of the mechanistic study. Now, because DPP-4 inhibitor is a serine protease inhibitor, and if you look back into some of the drugs which have been tried for the SARS-CoV-2, all serine protease inhibitor was found to have some kind of benefit in SARS-CoV-2 infections. Furthermore, the DPP-4 inhibitor was shown to have some anti-inflammatory, anti-fibrotic, and immunomodulatory properties in the mechanistic studies. And also, DPP-4 came into the limelight. If you see the COVID data, the severe COVID is happening more in elderly patients who are obese and in diabetic population. In all these population, the DPP-4 enzyme activity are very high. So it was proposed that if you use a DPP-4 inhibitor, it might be having some benefit in patients with COVID-19. But all these are propositions. Where is the data? So we reviewed the paper, all the paper published on DPP-4 inhibitor. This is a busy slide. Initial 4 studies suggesting no harm, no benefit DPP-4. The lower 2 study, when we published this paper, hinted of decreased severity in DPP-4 inhibitor. But we were stunned with this 2 paper simultaneously published very recently in Diabetes Care. And you can see both this paper came from Italy. One is from Lombardy and one is from Eastern Italy. Another paper is a smaller, 90 patients. The first paper from 338 patients was conducted with sitagliptin compared to placebo at the top of insulin receiving 2 parallel arms in this 2 small retrospective study. What is interesting to find that in both this study, there was a significant reduction in the sitagliptin users compared to non-DPP-4 inhibitor users. In the right-hand side, this is the entire class of DPP-4 inhibitor versus placebo in a background of insulin therapy. This data are small retrospective data, but too good to believe or having faith on, giving you such a good data, it is hard to believe. Now, the question is whether this data should be believed and should be used in clinical practice. There was a commentary, which was an invited commentary by Professor Michael Nock and Julius Meyer from Germany, and they wrote a commentary on this 2 particular paper published in Diabetes Care, that what is the reality? Is it true? If it is true, what could be the mechanism? So if you go through this paper, they came up with propositions for the DPP-4 might be doing benefit. As you know, if you use a DPP-4 inhibitor, you increase the level of soluble DPP-4. You know, the DPP-4 is circulated in body in two forms. One is membrane bound, another is soluble DPP-4. If you use a DPP-4 inhibitor, it increases the level of soluble DPP-4. So the moment it increases the level of soluble DPP-4, it is not allowing the SARS-CoV-2 to get attached with the membrane-bound DPP-4 and thus not allowing this virus to enter into the target cell like pneumocyte. So this was a proposed theory from Professor Michael Nock and team commenting on those two papers which came from Italy. And these are the propositions put forward for this paper. However, there are certain questions which needs to be asked. Furthermore, there are few, randomized control trial which is right now going. On your left-hand side is a study, a smaller study is being conducted with linagliptin. On right-hand side is with sitagliptin. These papers are supposed to be published somewhere in December 2020. Let's look for the RCT with DPP-4 inhibitor. As I was talking,
Dr. Singh will like you to finish soon.
Yeah, this is my last slide. This is my last slide. So despite these outcomes, several unanswered questions are still to be solved. First of all, we exactly don't know how long these patients were receiving metformin and DPP-4 treatment that actually offered any protection. What is the minimal dose of these two, class of drugs that has a putative protective effect? We don't know. What about the elderly populations receiving metformin? What about in a background of kidney disease or lactic acidosis? These are all some unanswered questions that needs to be answered before we suggest, these anti-diabetic drugs should be preferred. So, ladies and gentlemen, to put this perspective into conclusion, and this is my takeaways from these studies, we do have data which is, metformin as well as for DPP-4 inhibitor. Even if it is a retrospective study, but you can't deny the reduction in mortality even in the retrospective trial. Both metformin and DPP-4 has shown some merit. And of course, combination would be more, lucrative, but we don't have any evidence for this combination. Of course, before you conclude, you need to have a randomized control trial. Unfortunately, metformin is not undergoing RCT because there is no taker for metformin. However, for the DPP-4 inhibitor, as I said, there are 3 randomized control trials right now going, 2 with linagliptin and 1 bigger study with sitagliptin. Let's wait for the result from the RCT. For the moment, I would suggest not to stop metformin and DPP-4 inhibitor in patients with diabetes and COVID-19. Thank you very much for your patience listening.
Thank you, Dr. Singh. That was very informative, very well covered as usual, and it answers many questions. We are running short of time, but we'll urge the panel to the audience to type their answers in the chat box, and maybe we can forward those questions to Dr. Singh, and he can answer some of those questions. Thank you, Dr. Singh.
Thank you, Dr. Gupta. Thank you, my pleasure.
We move on to the next session, and which is a lecture on by Dr. Dinesh Khullar. Dr. Dinesh Khullar is an eminent nephrologist. He is a chairman and head of the Department of Nephrology and Kidney Transplant Services in MEX Super Specialty Hospital in Saket, New Delhi. And he has delivered various lectures. Earlier, he has been a part of Ahuja Bajaj Symposium several times, and he has received several awards. And today he will be talking on the common denominator, simplifying type 2 diabetes management in kidney impairment with linagliptin. Over to Dr. Khullar, please.
Well, thank you very much, Dr. Ritesh. And at the outset, my sincere thanks to Dr. Anup Mishra and the organizing team for this wonderful opportunity once again. It's always a pleasure to be part of Ahuja Bajaj Symposium on an annual basis. So I am, as you said, my topic for today is about simplifying type 2 therapy in kidney impairment with linagliptin. And as obviously, it's no denying the fact that linagliptin over a period of time has become really a nephrologist's favorite oral hypoglycemic agent because of so many advantages which it involves, and I am going to be talking about a few of them what the time permits me today. Well, it's important to understand that which is known to everyone, that patients with type 2 diabetes and kidney disease have a much higher mortality rates. And as you can see here, from no kidney disease to a situation whereby a patient has albuminuria as well as a reduction in GFR, the mortality goes up to as high as 50%. Well, Indian scenario is no different. Now, whether you look at what is shown on the left-hand side in this I Care for Diabetes survey, at least 1 in 2 patients of diabetes have chronic kidney disease. And if you look at the various factors which you look at, especially in terms of the GFR or the albuminuria, you cannot miss the fact that even those patients who have a glaring overt chronic kidney disease and overt nephropathy have more than 20% prevalence of CKD in type 2 diabetes. And if you were to carefully look, the number actually could be much higher, even more than 60%, and that's something highly worrisome. But the big problem here is, once our patients who have some chronic kidney disease and we have to, as nephrologists, try to control their diabetes, it becomes a big challenge for us because there are not too many which we can safely prescribe regardless of the GFR of these patients. As you can see here, there are very few which are allowed to be prescribed once the GFR falls to less than 30, and not too many even between the stage of 30 and 60. That's once the GFR goes to beyond stage 2 of chronic kidney disease, we are going to experience difficulties prescribing, barring linagliptin. And that's setting the ball rolling, saying as to why, as I said a little earlier, linagliptin has become a nephrologist's favorite DPP-4 inhibitor and as well as an oral hypoglycemic agent. There are various challenges which I'm sure everyone here knows. The typical challenges which we face once patient has a declining GFR, there has to be a lot of dose adjustment because many of these drugs are excreted by the kidneys, and also even the insulin gets renally cleared. So there is a reduction in the clearance there as well. We at any cost have to avoid hypoglycemia because our patients with advancing kidney disease tend to eat less, and they have more and more chances of hypoglycemia. And I'll be worrying more about hypoglycemia than a mild degree of hypoglycemia. Also coupled by the fact that kidneys, which are responsible for about 30% of gluconeogenesis, are not able to compensate with a decline in the renal mass. And the end result is there are more and more chances of hypoglycemia occurring in these patients. So first, I would want to avoid hypoglycemia, especially with whatever drug, anti-diabetic drug, which I use. Before that, we need to know whether the drug really is efficacious. Looking at linagliptin, if you were to prescribe linagliptin alone as monotherapy, as you can see here, when the baseline is close to 10%, quite a significant reduction in HbA1c with linagliptin, but it's even more when the baseline HbA1c was higher. And of course, as expected, if you combine it with metformin, and especially if the baseline baseline HbA1c was very high, you can expect a very meaningful reduction in the HbA1c of these patients. So with this in mind, we basically wanted to look at whether this kind of efficacy will result in hypoglycemia or not. In the Carmelina trial, which was quite an impressive trial involving a lot of patients, we have seen that regardless of the proteinuria or the GFR of the patients, you can be quite relieved to know that hypoglycemia is not going to be of common occurrence in patients prescribed linagliptin. And why is it so? Because linagliptin has just about 5% renal excretion as compared to the other DPP-4 inhibitors. And obviously, you will not want any kind of dosage reduction in linagliptin in patients with any degree of chronic kidney disease vis-a-vis all other DPP-4 inhibitors. And therefore, if we look at linagliptin, of course, there is no worry about dosage adjustment, and I'll come back to that in a short while from now as to why that is very, very important. And while most of the others will require dose adjustment, and in the drug that's linagliptin, where you may not really need too much of dose adjustment, there are some safety issues which are well known to most of us. Well, if you were not to use the appropriate dose of a given drug, there are chances that you will go haywire, and that has been seen in close to 50% of people prescribed DPP-4 inhibitors, that if you were not giving an inappropriate or the licensed dose, the problem is going to reflect very poorly in the long-term results. And especially when you look at the all-cause mortality, the risk of severe hypoglycemia, and the hospitalization risk, it will be quite significantly increased if you are not using the appropriate dose of a given DPP-4 inhibitors. Now, after talking about the efficacy and the reduction in the risk of hypoglycemia, we again would be interested in as to what kind of effect do they have on the renal outcomes. Well, when you look at the efficacy, again, even in patients with chronic kidney disease, there is going to be a significant reduction can be seen regardless of the GFR or across the spectrum of the renal disease, whether your patient has a mild renal insufficiency, has more advanced, is on dialysis, is a patient who is post-kidney transplantation, and if you have a new onset diabetes occurring after transplantation. So this is very, very important, and I think this gives you hardly any sleepless night. Well, we need to move on and see as to what do the recent trial, and especially Carmelina, which was specifically designed and statistically powered to evaluate not just the cardiovascular outcomes, but the kidney outcomes as well in patients of type 2 diabetes. As you can see here in the middle, where you have the linagliptin. Linagliptin in Carmelina trial had enrolled patients with severely reduced renal function, GFR as low as less than 30 ml, and this was a sizable population of 15% as compared to just about few percent when you look at the other competitor DPP-4 inhibitors. And when you look at any degree of renal insufficiency, of course, Carmelina recruited people in more than 50% of the cases, more than 60% rather. Well, if you look at the long-term kidney safety profile with the use of linagliptin, as was confirmed by the Carmelina trial, as you can see here, not much difference between the placebo arm and linagliptin. So you can safely conclude that linagliptin at least did not do any harm. But what we are interested in is knowing, when you use a particular drug to control diabetes, does it offer an added protection to the kidney? What I mean is, does it reduce the risk of progression of the disease, or does it actually induce regression of the disease? By regression, we mean the stage of macroalbuminuria going back to micro or normoalbuminuria. And let us see what Carmelina showed us. Lina was associated with a significant, and that's 14% risk reduction, relative risk reduction in albuminuria progression when compared to placebo. And when you look at the albuminuria reduction by more than 50%, it was seen in 15% of cases in the linagliptin arm as compared to the placebo. So you have seen both the things which you were wanting to see, and that has been amply highlighted by the Carmelina trial. Trying to figure out as to
please, I would request you to finish in 2 minutes.
Yeah, I'll do that. So as to why this would be happening, this is because it probably does not allow renal fibrosis to occur. There is inhibition of endothelial cells to mesenchymal transition occurring here, and that's probably good news, which is not seen with other DPP4 inhibitors, and this cannot be termed as a class effect. Well, fewer patients in the Carmelina trial actually required an increase in the insulin dose. And as you can see here, it had proved the cardiovascular renal safety of linagliptin across the spectrum of CKD in type 2 diabetes. As you can see in this slide, there's a convenience of a single dose without the need of dose adjustment when you're using linagliptin. And to conclude, it has a proven effectiveness and safety across broad range of patients, both in India as well as globally. There is, of course, as I've highlighted, no need for dose adjustment. It actually may be slowing down the rate of progression. It mitigates the renal fibrosis. There is a robust evidence and guideline recommendation for effective and safe use even in the presence of heart failure with linagliptin as against saxagliptin, which we know had some concerns. It has a long half-life, which ensures an effective 24-hour glycemia control, and we can use it in any age group, even in heart failure, renal impairment, hepatic renal impairment, heart failure, and in any race or gender. Thank you very much, and I'll be open to any questions. Thank you very much.
Thank you, Dr. Khullar. That was very informative and covered the topic very well. And as usual, the audience is requested to type the questions in the chat box, and we can later answer them. Thank you, Dr. Khullar.
We can
Thank you.
One question.
Right.
Sir.
Ritesh, any questions there?
Right now there is none.
Okay.
What about, there's one question, so yeah. What about teneligliptin role in renal disease? Yeah.
So I just briefly mentioned that yes, maybe we don't have the problems of dose adjustment and the extra risk of hypoglycemia, but then we all know that there have been safety concerns with teneligliptin, especially with the QT interval and things. So I would rather be feeling safer using a drug which has not been shown to be associated with any significant adverse events, even in patients with chronic kidney disease. So that'll be my take on this. And I briefly really did touch about this aspect during your talk.
Yeah, that's correct. Thank you, Dr. Khullar.
Thank
you. Now we move on to the next session, which is a special lecture on time in range by none other than Dr. Jyoti Dev Kesavdev. He is a pioneer in modern insulin pump therapy in this country, and he is based in Trivandrum and Kerala, and he has vast experience of insulin pump, and he'll be delivering his talk on time in range, the new HbA1c. So welcome, Dr. Jyoti Dev.
Thank you, Dr. Ritesh Gupta. And for me, a doctor from Trivandrum, it is a highly prestigious woman to be with this program. And we respect Dr. Anu Mishra sir, the great scientist from India, globally very well known. And thank you, Anu Mishra sir, for this opportunity. So in the next couple of minutes, I'll be briefly going through the topic that is allotted to me. And that is a very attractive title. Is time in range the new hemoglobin A1c? And I agree, of course, this is going to be, and this will be the new glycated hemoglobin. And I promise you that there will be at least 10% new information in my ongoing brief lecture. And these are my disclosures, and I will go back to the history. This is the International Diabetes Center in Minneapolis, and this is a very old picture of Roger Massey and Bergenstein when they used to work there in the late 1980s. And this is the first ever report on the ambulatory glucose profile by Roger Massey. And I remember this is in 1987 in the official journal of the American Diabetes Association. So what was he trying to communicate? He was trying to collect the data from the blood glucose meters, because when you are measuring the glucose and blood glucose meters, you get a lot of information. And in the CGM also, you get a lot of information. That is big data. So you need to somehow collect the data, and then we need to somehow translate this for decision making. And they developed the AGP, and subsequently in the year 2008, the IDC recommended AGP as the standardized glucose reporting format. But in total, it took almost 3 decades, for the AAs, and in 2019, the American Diabetes Association to endorse ambulatory glucose profile as the reporting format of glucose from any device. It can be a blood glucose meter, it can be any continuous glucose monitoring device, or it can be the insulin pump, where again, it can store the same glucose data. And in 2015, exactly 5 years ago, there was a revolution. And that was when Libre Pro was launched, the first ever factory calibrated continuous glucose monitoring device. Of course, we were using CGM for a long time. It was in 2005, we started using the CGMS Gold, but they were really cumbersome. But from this onwards, we learned that this is becoming more and more accurate. The interstitial glucose readings are becoming more and more accurate for us to establish the evidence from India. And these were the first 800 plus patients. And in almost every patient, we were making one change or the other subsequent to 14 days of continuous glucose monitoring. And the AGP meant the inter-day variability, the intra-day variability, and the AGP was quite different in type 1 versus in type 2 diabetes. Of course, it was different from glycated hemoglobin. And these are 2 patients. You have 2 patients, and this is a very, very popular picture in any CMA, having 2 patients with the same A1C. Here it is 7.7. But on the left, you have a patient with minimal glucose variability. But on the right, look at this patient. It has got significant glucose variability, both interday and intraday. So glycated hemoglobin has got its own limitations. It cannot predict, or it cannot identify the magnitude and the numbers, the frequency of the variability. It doesn't reflect the acute glucose excursions. And in iron deficiency anemia, in physiological conditions such as pregnancy, or in hemoglobinopathies, which is highly prevalent in many parts of India, A1C, will be wrong. And because of so many reasons, we require other glucose metrics. So these are the glucose metrics originally discussed at the ATTD 2 years ago. And the group recommends a standardized CGM report, which could incorporate the key time in range metrics and targets along with 14 days ambulatory glucose profile. And these are those 10 key metrics. You need to have the CGM on for 14 days. And of the 14 days, 70% of the data is required. And the 70% will represent minimum 10 days of wear of CGM. And then the mean glucose, the glucose management indicator, the glycemic variability, which should be still lower in those patients using those drugs prone for hypoglycemia. And then you have those 10 key metrics there. The time in range, which is between 70 and 180, the time above range, level 1, level 2, and time below range, level 1 and level 2. So this is the broad view of the 10 key metrics selected and recommended by the consensus panel. And what is objective? The objective is very simple. The objective is to increase the green zone, to increase the time in range, and simultaneously to reduce the time below range to avoid hypoglycemia. Do we have evidence? Of course, these are some of those evidences, and these are from the older clinical trials on the time in range associated with the development of microvascular complications. So when the patient is in more time in range, then there is less of the frequency of retinopathy and neuropathy. And this is the data for every 10% lower TAR, retinopathy increased by 64% and microalbuminuria increased by 40%. So there is no dearth of evidence for the time in range. And this is Bob Vygotsky at one of our international conventions in India. And Dr. Anu Mishra sir also used to be our chief guest every year in Trivandrum for this international convention. And Bob Vygotsky is one among those scientists, along with others, Beck et al. And McMohan, to publish the direct correlation between the two, the time in range and the glycated hemoglobin. So I would say that a time in range of 70% could correlate with a hemoglobin A1C of 7% in both type 1 and type 2 person. And for every 10% improvement in the time in range, from 70% to 80%, from 80% to 90%, there is a corresponding A1C reduction by 0.5% or up to 0.8%, both in type 1 and type 2 diabetes put together. And in the February, we have presented and published the data from India on the correlation between A1C and time in range, and this is from the Asian Indian population. And we have this in DTT as well as at the virtual conference at Chicago of the American Diabetes Association, closely correlating with the Caucasian statistics. So what are the recommended targets? And these are the key points for the evening. And these are the numbers. In both type 1 and type 2 diabetes put together, the time in range should be more than 70%, between 70 and 180. And this 70% corresponds to more than 16 hours, 48 minutes for the patient. And the time below range, level 1 below 70, less than 4% in 24 hours. And this corresponds to roughly 1 hour when we are communicating with the patient. And level 2 hypoglycemia, less than 54, that corresponds to less than 15 minutes when we are corresponding or when we are communicating with the patient, and that is less than 1% in 24 hours. And this is time above range, level 1 above 180, less than 6 hours, and level 2 above 250, less than 1 hour and 12 minutes. What about those patients who are critically ill, or those patients who are having propensity for a hypoglycemia? Elderly, please remember, elderly is not defined by the chronological age. Elderly is defined in this criteria via the functional or the biological age. And for elderly with multiple comorbidities, the numbers are the same, but the time in range need to be only above 50% in a day. That is 12 hours in a day. And our objective is to prevent time below range. Even below 70 milligrams should be less than 15 minutes in 24 hours. And time above range, that is above 250 milligrams, less than 2 hours and 24 minutes in a day. And for every incremental 5% increase in time in range, there is an associated clinically significant benefit in both type 1 and in type 2 diabetes. We have a different criteria for pregnancy. Of course, we have different numbers in diabetes or pregnancy. And this is for type 1 diabetes and pregnancy. And this is between 63 and 140, not 70 and 180. And this is again the same, more than 70% to be in range. And level 1 below 63, less than 1 hour, and below 54 time below range, that is less than 15 minutes in a day. And time above range is just above 140, and that is less than 6 hours, corresponding to less than 25% of the time in 24 hours. In pregnancy, remember, for each incremental 5 to 7% increase in the time in range, there is an associated clinically significant benefit for pregnancy in women with type 1 diabetes. But for type 2 diabetes and pregnancy and for GDM, we don't have sufficient data to recommend currently the time in range. Also, this is a summary of the different population that I have discussed, and these are the colors. The green denoting the time in range, and then you have the orange and the dark red denoting the time below range, and this is the time above range, level 1 above 180, yellow, and above 250, dark yellow. And what about those patients? Because I do understand that majority, maybe 85 to 90% of the patients in India, they cannot afford a CGM unless and until the price is coming down. And for the common man, probably, though it is only approximate, we may have to have these connected glucose meters, which can connect via the Bluetooth and provide a time below range or time above range in the mobile phone app itself. Of course, the patient need to measure the glucoses more number of times to have these quick averages. And these are the recommendations by the American Diabetes Association in their 2020 clinical practice recommendations. And they have published a model AGP report. You should have the 14 days of recording, and this is the representation as a 24-hour model graph as an AGP, along with the bar representing the time in range and the individual day profiles for motivating the patients, for educating the patients. And what is new in the Indian market? So I will spend another 1 minute discussing the newest gadget in the Indian market, and that is the Libre. We were having only Libre Pro, and Libre comes with a reader, and the reader can provide you with a daily graph as shown here. It can provide you with trend arrows, and it can provide you with an arrow pointing upwards, representing that glucose is increasing at the rate of 2 milligram per minute. That means it will increase by 60 milligrams in the next half an hour. And if it is horizontal, then the increase or reduction in the glucose is less than 1 milligram per minute. And the reader can also provide you with the same time in target, time below target, and time above target. So I will show a demonstration. I have a demonstration of the reader here. So I am having a sensor on me, and this is how it is read. So my glucose value now is 135 milligram, and the trend arrow is horizontal. So the glucose is remaining stable, and I can go to the review history, and I can also have the time in range from the side. So it shows that I am in target 99% of the time. Of course, since I am not having diabetes, my target is set as between 70 and 140, but ideally it should be between 70 and 180. And this sensor will be there for 14 days, and even every minute I can scan and get a report. So it is very simple, and it is currently available in India. So in conclusion, I will say that anyway, the American Diabetes Association has endorsed time in range, and hence probably we may have to utilize AGP and time in range routinely in our practice. And these new glucose metrics are probably superior or complementary to the glycated hemoglobin. These technologies are not for every patient with diabetes. Of course, we need to customize whom will benefit the most for preventing. Our objective is prevention of long-term complications of diabetes. So thank you very much for the patient hearing and for this opportunity.
Excellent presentation. Ritesh, is there a question for Dr. Jyoti Dev?
Right now there is none, but we'll take questions as they come. Yeah.
Okay, thank you, Dr. Jyoti Dev. A wonderful presentation, and we have all benefited from it. Thank you so much for joining us.
Thank you, sir.
Ritesh, please go on with the next.
Now we move on to the next session, which is a small, short talk on a very interesting topic. Mangoes. We in India, we always talk about mangoes, and our patients often ask us whether they can have mangoes or not. So this is precisely the question which Ms. Sugandha Nair is going to answer. Sugandha is in charge intervention studies with nutrients at NDOC, and she has conducted some studies with mangoes, and she has done studies on other nutrients also. So she will be talking on mango and diabetes, to eat or not to eat. It will be a short lecture. Thank you. Yes, Sugandha, you can start.
Yeah, good evening. Good evening. I'm going to speak on mangoes to be eaten in diabetes or not. Starting with the background, the scientific name of mango is Magnifera indica. It belongs to the family of Anacardiaceae in plant classification. Mango is a national fruit of India, Pakistan, and Philippines. It is a national tree of Bangladesh. It was first cultivated over 4,000 years ago, and now it is widely cultivated on an area of approximately 3.7 million hectares worldwide. Top 3 mango producing countries in the world are India, China, and Thailand. Mango is a native to Southeast Asia, particularly India. Mango was first grown in India. Buddhist monks are believed to have introduced the fruit first in around 4th BC. The earliest name given to mango was Amra Phal, meaning the food of the gods. India alone accounts for 54% of total world mango production. Top 3 mango producing states in India are Andhra Pradesh, Uttar Pradesh, and Bihar. Coming to the nutritive value, mangoes are an important source of macronutrients, micronutrients, and has abundant of antioxidants. 100 gram of mangoes, which is approximately 2 slices depending upon the variety, has only 74 calories, 16.9 gram carbs, and only 0.4 gram of fat, which is considered negligible, and it is high in dietary fiber. It provides all essential vitamins. It is a rich source of vitamin A, folate, vitamin C, E, and K. It is high in minerals, particularly calcium, potassium, magnesium, and sodium. Mangoes also contain good amount of polyphenolic compounds which act as antioxidants, magniferin being the most important, after which the mango has been named. Despite being low in calories and rich in antioxidant, mango is often restricted from the diet, whereas cereal products are freely consumed as a staple in India. So let's have a look at the comparison at the nutritive value of 100 gram of mango and 100 gram of wheat. 100 gram of wheat contains 341 calories, which is thrice more than that in mango. We can see that mango contains much more carbs and fat than wheat contains much more carbs and fat than mango. The difference between the keratin content can also clearly be noted. 2 slices of mango provides 10% RDA of keratin and nearly 70% RDA of vitamin C. It is also rich in magnesium and sodium. Now it is very important to note glycemic index of mango, because due to its perceived sweetness, people with diabetes often refrain from eating mango. So mango has glycemic index of 51 and glycemic load of 8, both of which are considered as low in, they are categorized as low in the classification. When compared to other fruits, mango has less glycemic index. Fruits like papaya, pineapple, guava, they have higher glycemic index. And when we talk about the cereals, which we consume on regular basis, cornflakes, rice, bread, they have much higher glycemic index and glycemic load than mangoes. Coming to the studies conducted on the mangoes, they are very few. There is a lack of data in both Indian subjects and also in human subjects, as most of the studies, they are conducted on animal models. This table, it shows the studies conducted on mango in India and other countries. Ray et al. Study, this I'll take in the next slide. Gandhi et al. Study, this was carried out to investigate the effect of mango peel in improving diabetes in diabetic rats. And it was observed that mango peel supplementation reduced urine sugar, urine volume, and improved lipid profile. Bhumika et al. Study, it was conducted on type 1 and type 2 diabetic rats to study anti-diabetic effect of mango stem, bark, and leaves. and a significant anti-hyperglycemic effect was observed when extract from mango stem bark and leaves were induced to diabetic rats. Evans study, this also I'll take in upcoming slide. In Spain, a study a study was done to see the effect of mango fruit powder supplementation. And it showed that it reduced body weight, body fat, LDL, and improved blood glucose, HOMA-IR, and fasting insulin levels in mice fed with high-fat diet. In another study, consumption of 400 gram of mango pulp for 42 days lowered blood pressure in lean individuals and HbA1c in obese individuals. This is an Indian study to compare postprandial glycemic response to equal quantity of mango and white bread. Here, 50 gram of mango and 14 gram of bread are taken as reference food, as 50 gram of mango produces similar glycemic response as that of 14 gram of white bread. So after overnight fasting, the subjects were given measured amount of mango and bread on different days. Blood samples were drawn in fasting state at every half an hour up to 2 hours of consumption. This is glycemic response of people with diabetes, and this is for non-diabetic subjects. In both the figures, we can clearly see that bread exerts much more glycemic response than mango at 30 minute, 60 minute, and 90-minute interval. According to the authors, this could be because the total moisture content in mango is almost double to that in bread. And therefore, the sugar content in mango is about half the available sugar content in the bread. This study was conducted in USA in a variety of mango that are not available in India. In this study, 20 obese adults were given 10 gram of dried frozen mango pulp for 12 weeks. The subjects were instructed to maintain usual diet, exercise, and medication routine. Results after 12 weeks of mango consumption showed reduction in blood glucose levels in both males and females, increased insulin levels and reduced hip circumference in males, and no significant changes in weight, percent fat mass, and waist circumference was observed. It concluded that mango has a positive effect on blood glucose, especially fasting blood glucose, and does not negatively impact the body weight. We generally come across many myths pertaining to mango. People generally think that mango is sweet in taste and therefore it will increase glucose in their body. But they are unaware of the fact that starch breakdown produces sugar irrespective of whether the food is sweet in taste or not. Many people and even health professionals think that mango increases postprandial glucose. And this is a myth, as I just shared a study that clearly stated that mango does not increase postprandial glucose. Mangoes are also believed to increase weight, whereas the truth is that mango has negligible fat and zero cholesterol. In fact, it is rich in dietary fiber, which keeps us full for longer time, pectin, which lowers cholesterol and glucose levels in blood, in beta carotene that reduces risk of cancer. And mango is also said to be heat producing and causing skin problem. But the fact here is that no fruit can produce heat in the body. Mangoes are grown in summers when skin infections and acne are most prevalent. And this could be the possible reason that why mango is often mistakenly associated with skin problems. Thank you.
Thank you, Sugandha, and that was very informative.
Ritesh, now, if you allow, I'll take over from here.
I'll just announce the winners of the.
You have that winners.
Yeah.
Okay.
Yeah. Then we'll quickly announce. So for the first question, which was on omega-3 on monounsaturated fatty acid content in olive oil, we have 3 winners: Dr. Shyam Adhav, Megha Mukhija, and Rekha T. And congratulations to all three of you. And for the second question on the hypoglycemia, the winners are Mr. P. Jitendra, Dr. Harpreet Bajaj, and Dr. H.S. Das. And congratulations again. We'll contact you soon for the prizes. Thank you.
Great. Ritesh, you are giving good amount of prizes. These are difficult questions that you put. So great people have answered, and Harpreet is no surprise, of course. He knows almost everything. So thank you, Ritesh, for conducting that session, those lectures beautifully, and conducting this quiz. And we'll come back with more of questions tomorrow. And Ritesh has put some degree of difficulty. So, so be prepared for difficult questions. So thank you, Ritesh. We move on to plenary sessions now. And we have a very, very distinguished speaker among us, and whom I know for last 25 years, and from my days in All India Institute of Medical Sciences, he's one of those people who have been trained by Professor Bajaj and Professor MMS Ahuja. We are very glad to have Dr. Professor Om Ganda from Jocelyn Diabetes Center, very, very distinguished center, and he has been co-investigated a number of NIH-funded trials, including DCCT trial and reduced trial, etc. More than 200 publications, number of distinguished societies, and he's a pioneer in every sense. And he's a pleasure to listen to. And he has published a lot on the topic of the lecture that he is going to give, and that topic is very close to his heart, and that is frailty, aging, and diabetes. So welcome, Professor Ganda. Thank you very much for this invitation. You're coming on our platform, and it's an honor to have you here.
Thank you very much, Anup. Can you hear me okay?
Yeah, we can hear you very well, sir.
Okay, let me get my slides on. It's such a pleasure to be participating in this symposium, a very, very important symposium, Anup, and thanks for inviting me. I just have fond memories of All India Institute, where I did my MD in medicine and left to come to US in 1971. So it's incredible how time flies. And so it's such a pleasure to give a talk on a topic on which I've not done that much research, but I certainly am very interested because I think I'm getting into an age group now where some people may call me getting to that aging group, having been on the scene for about 50 years. But in the interest of time, let me just jump on and start with my first slide, just to commemorate both of my esteemed teachers and mentors, Dr. Ahuja on the left and Dr. J.S. Bajaj, of course. I miss them dearly. Dr. Bajaj visited me at my home a couple of times during my early stay here. And he was really exemplary physician. He taught us with a great zeal and zest, and he came to the ADA meetings. And one thing I would mention, that he was at the ADA from the sessions pre-official meeting starting at 5:30 a.m. and he would stay on till about 6:30 p.m. when the last session ended. So he was so meticulous about never losing sight of more knowledge and learning more as much as he could grasp at each meeting. Dr. Bajaj, on the other hand, was also an exemplary physician who came back to the Institute from UK during my first year at the Institute when I was a first-year resident. And I will just mention one thing, that Dr. Ahuja actually participated in the WHO triglyceride study with Kelly West, the Kelly West Award that is given in the field of epidemiology. And so he worked with him, and he was the second author on this very landmark paper published in Diabetes Care in 1983 as one of the highlights of his career. And Dr. Bajaj was working with Professor Valence Owen in UK, and he returned to the Institute, as I said, during my first year of residency, and he worked with Dr. Valence Owen on syn-albumin antagonist. And of course, rest is history as far as Dr. Bajaj is concerned. One personal note, I still vividly remember every evening we will have rounds with him, especially on Saturday evenings when we'll see newly admitted patients from the emergency room. So what a delightful experience, and how much we miss these two legendary people. I'm going to quickly talk about and touch on basically in this limited time on the prevalence and definition of aging population. Biology of senescence and geroscience is like a 2-hour lecture by itself. I'll say a few highlights in 5 minutes. Can we halt or reverse senescence? That's obviously the key question. And I'll mention a couple of trials that are going on. What is the current progress in the care of diabetes in aging people? So some clinical highlights and key research gaps. So let's move on. This is the IDF 9th edition, the latest atlas, well known to you, and just reminds us that the aging population is increasing everywhere. Here they're talking about number of people, top 10 countries where people in the age range of 65 to 99 throughout the world. India, of course, does not have as many aged people yet because the longevity is actually lower than many other countries, especially United States, but still there are 18 million people, and this number is going to swell to about, I think about 30 or 40 million people. I can't see it here. There we are, about 28 million people by 1945. Okay, how do we define aging? Obviously, it's a heterogeneous trait. You can define it by chronological age, by functional status, and by comorbidities. And everyone agrees that we just cannot define it by chronological age. We have to think about this as a disease, not a disease, but a condition which depends upon the other two factors. And actually, the current consensus is that you can divide the people above the age of 65 into 3 groups. Number 1, good health, little or no cognitive or functional impairment, and long life expectancy, 10 to 15 years. Number 3, the group number 3 is people with several comorbidities or disabilities or both, and people who have life expectancy of less than 5 years. And group number 2 is everybody in between. I think that's a well accepted definition now throughout the world. Now, we know that aging is really important because it's associated with so many chronic conditions. And basically, if we didn't have aging, or if we could cut down or stop aging, we won't have things like dementia, cancer, Alzheimer's, heart disease, diabetes in a large way. We can abolish these. So the biggest risk factor for all of these conditions is age, rather than any of the other risk factors. And that's not it. There are many others, starting with frailty, sarcopenia, bone problems, joint problems, fall, CKD, and so on and so forth. And let me see if I can get this out of the way here. I just wanted to talk about, since we are in the COVID era, that if you have COVID, COVID-19 increases the mortality 180%, 180 times if you're age 80 versus age 20. So we know that COVID is really a big issue, and hopefully we're going to overcome it, hopefully by next year, hopefully even by next summer, and we can't wait. And nothing like coming over there, or you guys coming here, and we all mingle and talk to each other in person, rather than what we are doing now, the next best thing. Okay, so biology of aging. What are the proposed mechanisms? This is just a short laundry list, but some of the most important factors where research is currently going on. Genomic instability, epigenetic changes, dysregulated nutrient sensing, stem cell exhaustion, you name it, telomere shortening. And our lab, actually, one of my colleagues, and actually several colleagues working in their lab, are looking at the cellular senescence and the secretion of the senescence-associated secretory profile. I'll show you one slide on that because something that I'm more familiar with their work, working at Joslin. Okay, now, what are the current and potential approaches under intensive study? Number 1, there's no doubt about it in my mind that caloric restriction okay, say about 30% caloric restriction. If you can do it, it's a very good way to curtail aging. Okay, this started with studies in nematodes, ascaris, or some of the Drosophila, for example, in the fly, which has been studied quite extensively. Then we have things like metformin, acarbose, mTOR inhibitors, rapamycin, with or without metformin. In fact, studies are going on in this field very intensively right now, both in animal models and in humans. NAD precursors and sirtuins, and I mentioned modifiers of senescence and telomere dysfunction and mitochondrial targeted agents. So there's huge interest and a lot of funding coming out from NIH and other agencies to try to see how we can overcome some of these severe problems associated with aging. Here is one slide on effect of caloric restriction, published in New England Journal now almost 25 years ago. And it's a classic study. I would recommend everybody to look at it. So this is a study done actually in mice and shows you how much you can prolong survival by simply cutting down the caloric intake from ad libitum right here to modest reduction, going down to 85 calories here, 50 calories and 40 calories per week, et cetera, et cetera. And the mechanism appears to be basically that you have reduced oxygen consumption when you restrict your caloric intake, and you actually reduce your superoxide production, okay? So that probably is the main mechanism. And we heard a lot about, modified fasting, alternate day fasting, all of these fasting regimens. The basic principle behind them is some caloric restriction. Okay, let's go to the next slide. This is a very important paper that was published actually last year in Stem Cell Biology Journal, where they talk about metformin, how metformin restores CNS remyelination capacity. So as we age, our differentiation of various cells go down. Here we're looking at oligodendrocyte precursors. So the young OPCs gradually get lost. Aged oligodendrocyte precursors begin to accumulate, and metformin may provide a signal to reverse this process. This is one of the many mechanisms that have been talked about, or metformin also for fasting. So metformin has been appropriately been receiving a lot of attention. There are no final answers yet. Let me remind you, there is no final answer. We still are looking at many of the studies that are going on in this area. Here is a study that some of you may have seen. This is a human study from Australia, among many other studies that I mentioned. This is a study recently published in Diabetes Care, September 23rd, less than 2 months ago. And the important part of this study is, unlike many other studies where they look at cognitive issues, they looked at those studies in the past have been in younger people, like 50s and 60s and so forth. They actually looked at people where it matters, age 70 to 90, 1,000 or more people, 10% had diabetes, and they were on metformin. Follow-up was up to 6 years. So in this small group of people with diabetes, when they look at, including the rest of the population, you find that the global cognition was improved almost to the same extent as people without diabetes. Again, let me just, I'm looking at this side column here. Yeah, there we go. Executive function was improved all the way from going downhill to the non-diabetic level, and dementia-free survival. So I think, as I said, many of you may have seen this paper because it just appeared very recently. So what are some of the ongoing trials? I think the main trial that I'm very interested in that's really now underway is called the TAME trial, Targeting Aging with Metformin. This is being done by the group at Albert Einstein, who are the co-chairs of this study. This is a series of 6-year clinical trials at 14 leading research institutions across USA that will recruit more than 3,000 individuals in the age range of 65 to 79. And I think this will be one of the landmark trial that we need to look forward to before we can be making any conclusive statements. Okay, now I promised you I'll show you one slide from the work of Christina Mazzucato at Joslin. She's been looking at acceleration of beta cell aging by this process of senolysis. So we know that this is in animal model that with insulin resistance over the course of years, you accumulate aging beta cells. And these aging beta cells shown in red here cause the destruction of beta cell or loss of beta cell function. And if we can find a way by genetically removing these older cells by senolysis, let's say, or the term that you can use for that, you actually have a return of the beta cell function. You restore insulin secretion and you restore gene expression. So they're using technology of CRISPR and other technology to find a way to remove these aged senescent cells to make the younger cells proliferate better, and thereby, even in humans, achieve some degree of loss of senescence. So this is a very, very exciting new concept, and the clearance of senescent cells, we know from the animal experiments, it improves glucose levels, beta cell function, as well as indirectly insulin resistance. And in humans, beta cell senescence obviously is a key factor leading to type 2 diabetes and may even be important in type 1 diabetes later on. Okay, so with that said, let me just highlight some recent clinical insights. I'm very acutely aware of the time commitment that I have, but let's start with a couple of things. Does intensive control help in the aged? That's been a question that's been addressed more recently, because a lot of time we think that we must control diabetes as well as we can. We should, but when we get people in the age range of 60s and 70s and 80s, is the intensive control as helpful? Well, this is a huge database from the Swedish Diabetes Register, I'm sure known to some of you, at least worth studying. They have published many papers in New England Journal, Lancet, and so forth. And this just highlights the fact that if you look at the total mortality in these 2.5 million people in Sweden, where there's a, obviously very structured diabetes registry, you see that as you get older, 65 to 74, or certainly over 75, A1C becomes less and less important. So some of you are already applying it in your practice. We all are very aware of this fact that in older people, we should not be shooting for very tight blood sugar control. But all around the world, it's not happening, even though we have this kind of data. This is total mortality, that's CV mortality. Look at what's happening here above the age of 75 compared to people under the age of 75. So the hazard ratio for both mortality and CV mortality is much smaller when you get older. Okay, and we know that when we do intensive diabetes control, especially with sulfonylurea, insulin, etc., meglitinides, we know from the advanced study shown here that severe hypoglycemia is a big problem. And not only is it a big problem for cardiovascular death, but even for non-cardiovascular death. And it just basically signifies a sicker person. It's not that they're dying just from hypoglycemia, but they're dying from other comorbidities that exist in people who develop severe hypoglycemia. So this is a concept which has to be understood, that it's not just the hypoglycemia, it's also non-hypoglycemic comorbidities that these people have. So I think one has to be aware of this very important observation clinically. So is it happening? Well, it's not happening. Here is the great data from Kaiser Permanente in the US, a very large registry, 21,000 people, 4-year follow-up after people turned 75. And you can see people divided into good health, intermediate health, or poor health, frailty. Okay, you can see that this is patients prescribed insulin at age, as mentioned. So even at age 75 and beyond, even people in poor health almost as many people are getting insulin, even when the A1C is 7 to 8.4 or even less than 7. Look at this number. These are the people in poor health compared to those in good health. And here, as a corollary, you can see insulin discontinuation rates after age 75 by health status and A1C categories. You can see once again, even when the A1C was less than 7, let alone 8 or 8.5, not too many people were asked to cut down or discontinue actually insulin in this particular case. So this is actually the real life data, that we have to address. So de-intensification of glycemic medications should be a goal in older people. This is just another example. Looking at the VA cohort, very large cohort, age above 70. It's a retrospective study, but still important. Blood pressure medications, the rate of discontinuation or cutting down was only about 15 to 20%, less than 20% for blood pressure medications. And even for A1C, you can see even when the A1C was less than 6%, 6 to 6.5% and over 6.5%, these people continued to get their, all the glycemic medications, including insulin, which is hard to believe, but that's the real life data that we have to address. Okay, now we did a study recently. We heard a whole talk on CGM, and my colleagues, Elena Toshi and co-workers recently published this paper in Diabetes Care, just I think about a month ago, where we looked at 130 people age above the age of 65, type 1 diabetes for 40 years almost, A1C 7.3. And the point here is that CGM has been a big help, even in older people. So you can see here in this particular group, this is the normal goal. Okay, time in range, we like it to be above 70, and time above range less than 75, and hypoglycemia less than 5 altogether. But here there are two groups of people among these 130 people above the age of 65, where you can see they all had the same A1C of 7.3%. But what I can't see here, let me just see if I can raise the slide. Yeah, there we go. No. The point here is that the coefficient of variation of blood sugar levels was lower in this group compared to this group. So when we do CGM, we should look at what is the CV, what is the standard deviation. So you can, if you have a same A1C, but your standard deviation is lower or SEM is lower, then you have more people within goal, time in range, less people in hypoglycemia. But most importantly, you can see here that the hypoglycemia almost vanished, went from 7% to about 2.7%, especially the severe hypoglycemia defined as blood sugar less than 54 went down from 3.2 to 0.6. But even those under 70 went down quite a bit. So I think if affordable, if people can afford it and pay for the cost, hopefully the cost will come down. I think older people, especially those who are on insulin, must get CGM. And almost everybody on insulin who is on multiple insulin injections, according to our criteria, who monitors blood sugar 4 times a day, is eligible to get CGM, at least in the United States. I'd like to hear your opinion and what's happening in India in this regard. Okay, I don't need to dwell on this. These are the ADA 2020 guidelines, not very different from the 2018 and 2019, which remind us that the goal of A1C should be higher in people who have very complex, poor health, less than 5-year survival expectancy. The goal should be less than 8.5. Some have even said 9%. If you have multiple comorbidities, but still have more than 5-year life expectancy, your goal should be less than 8%, and so on and so forth. So same applies to, I won't get into, the whole area of statins and lipid goals and blood pressure goals in this presentation. Okay, now I want to end on just a couple of remarks on a very important international geriatric workshop that was carried out in Boston by my colleague Medha Munshi and all of us represented here, where I played a small role. We met in Boston about a year ago, and this paper was published in Lancet Diabetes Endocrinology in August of this year. So the whole idea was that with a lot of incomplete knowledge and a lot of confusion about how should we proceed clinically in treating patients with diabetes who are getting older, and how should we address the major complications such as cardiovascular complications, neurological complications in both type 1 or type 2 diabetes. So I think this was a very fruitful meeting, and a lot of concepts were discussed, starting with mundane things like screening and diagnosis and prevention of diabetes, comorbidities, glycemic goals, glucose-lowering agents, type 1 diabetes and aging, how do we apply technology in this population, and long-term and palliative care. So we discussed over the course of 2 days all of these factors, and I just want to give you one example, which is the area that I addressed, and that happened to do with the limitations of cardiovascular trials and the evidence gaps that exist in older subjects. So these are the following questions that I summarized in my presentation. So are the reported cardiovascular trials truly meaningful in the older population with comorbidities? Do CVOTs differ in ethnic group, particularly in the elderly? Would the heart failure outcomes with SGLT2 inhibitors be as robust in the older population who may have cardiomyopathy and other reasons for heart failure? Are the renal protection results reproducible in the elderly with advancing age, such as people with CKD, with GFR in stage 3B, GFR less than 45? Are they safe? So the answers to these questions are really not there, and we need more studies. Could the older patients have tubular damage from the long-term glycosuria? This is not just the older patients, but actually even more so in younger patients who have many more years to live with the SGLT2 inhibitors. These are great drugs, but are there any adverse consequences long-term? Something to consider. So here are some examples. We know the heterogeneity of cardiovascular events. For example, look at these major trials like EMPA-REG. Interesting to note that even though people above the age of 65 seem to do better in this trial, but remember that age above 65 was excluded in parts of Asia. So we really don't know what happens in this population. LEADER trial, for example, showed us that if you are older than 50 years of age and established cardiovascular disease, you may benefit. But if you're older than 60 years of age and have risk factor for cardiovascular disease, you may not benefit as much as you do in younger people, relatively younger people, shown here. Ethnic minorities have been well underrepresented. Asians, for example, the major trial that have been carried out, these are most but not all of them, anywhere from 9%, 8% to at the most 20%. So we need more data in Asian populations. So let me end on just making the optimistic point, and that is that not everybody ages the same way. Of course, we know that, and it's not inevitable, you know. So we have to inherit the right grandparents, and we have to choose the right parents in order to live longer. Okay, I wish that was possible. But here is one example which recently came to light. That is this woman who is 103-year-old who survived COVID-19. She's having a nice Bud Light beer in her bed before going home. And when asked if she was ready to go to heaven, she replied, "Hell yeah." So that's some of the people who get so lucky. Thank you very much.
Thank you, Professor Ghana. That was a wonderful lecture, very interesting. And thanks for providing us all the insights into the aging. I have just one quick question. Metformin is such a wonderful drug, and we say that diabetes increases aging, means makes aging faster, and metformin is something which may have effect on the aging and cognitive function. So, should we use metformin in preference to any other drug, even SGLT2, in people who are older?
Yeah, so I think that's a very good question, comes up all the time. As you know, the FDA has changed the label for metformin. Remember, for the longest time, they used to put down creatinine 1.5 and 1.4. And in people above the age of 80, they used to say, oh, measure creatinine clearance, which is kind of, makes no sense these days. So I think now the label has been changed to go with GFR. And I think, as you know, a couple of years ago, I think 2017 or 2018, it was decided that we will not stop metformin, even in people who have stable heart failure. It may have a history of decompensated heart failure, but that label that people with heart failure should not use metformin is really wrong. So if they are stable and the GFR now down to 45 to start metformin and 30 to stop metformin. So we are using metformin much longer now, as long as the GFR of 30 to 45 would allow. Yes, we should cut down the dose of metformin if the GFR is less than 45 in people above the age of, say, 65 or 70. But again, it depends on the patient. So I think I have a lot of people now in their 80s and 90s who have excellent renal function. So I don't see any reason to stop metformin. And not that I'm convinced that metformin is helping them aging-wise. We'll find out in a few years.
Thank you so much. That was wonderful presentation. We are very thankful to you for joining us, and I'm sure in the future, our future events will again send you invite for further deliberations. Thank you so much, Professor.
Great to be here. Thank you very much, Anup.
We move forward with the presentation. We have three excellent and interesting lectures, and the next speaker is a very distinguished diabetologist, Dr. Harpreet Bajaj, who has initially done his graduation from here and then moved to United States and then now in Canada, and doing wonderful work as far as the education is concerned. He is a vice chair of clinical practice guidelines in the National Executive of Profession for Diabetes Canada, and he has done some excellent research work. One of the papers were published recently in New England Journal of Medicine, and which chose this paper for his presentation. And this is going to be a wonderful presentation, I'm sure, because this is something which is I don't know anything, and most of the people will not know about this once weekly basal insulin, and we are waiting for it. Thank you, Harpreet, for joining us. Please go on with your presentation.
My pleasure, and thank you for the kind invite, Dr. Mishra and Dr. Gupta and the organizing committee. This has been a great educational session. I've learned a lot, from every speaker, in fact. So thank you for putting together this great educational initiative, which you do every year. And this is the first time that I've attended. So I'm hooked for life. So I'll be attending every year for sure to get my education as well. So thank you. It's a difficult task to follow up on Professor Ganda to go on to a different topic. Hi, Professor Ganda, if you're still there. I'd heard, when I was at Cleveland Clinic, I worked with Dr. Mehta, Adi Mehta, you probably know him, right? And he used to speak a lot about you and him. And so it was great to at least virtually meet you for the first time as well. All right, so moving on with the topic at hand, which is once weekly basal insulins that are in clinical development. So note, these are not currently available anywhere in the world, but these are in clinical development and hopefully will prove to be game changers in the future, and we'll discuss why or how. Before I begin, as is customary in Canadian CMEs, here's my full disclosures. I don't do much CMEs these days because of my involvement with Diabetes Canada, as it is a conflict of interest. Before I go to the future, let me begin with the 100-year history of insulin, which has to do a lot with these two fine gentlemen, Nobel Prize winners, Banting and Best, and others, who discovered insulin about 100 years ago. And the dog that you see in the picture, her name is Marjorie, was the first recipient of that insulin. So insulin has undergone a lot of innovation over the last 100 years. We have faster acting bolus insulins. So in a sense, make it even faster so that it controls the peak of glucose with carbohydrate load. But that has hit a roadblock, I would say. And I'll compare the story to the hare and the tortoise story. So of course, the bolus insulin is the rabbit that, okay, make it faster, run faster, but then you hit a roadblock because how much faster can you go? And is there a need for faster insulins as well? Whereas the basal insulin innovation can be compared to the tortoise who wins the race, because there is a lot of need to continue to innovate further on the basal insulin story. Let me go back to the insulin story and show you how. So the past, and the present of the insulins is what I'm showing in this slide. So of course, we've had the NPH insulin, and before that, animal insulins as well. And then we got the first generation insulins. So these were the glargine U100 and detamir insulins. And more recently, we've had the ultra long acting, or the second generation analogs, if you will, like the degludec or the glargine U300. So they have a longer duration of action, up to 42 hours for degludec, for example. But still, one thing that has stayed stagnant is the need for a daily injection of insulin, which if you ask the patient, it's not their preference. So I think the future, the innovation that is being developed or in clinical development of once weekly insulins is going to transform how we view insulin and how our patients view and take insulin as well. So let's delve into that a little bit. But before I do that, I'll also invite you to read, if you have a chance, on Medscape, this column. I write a column on Medscape called Sugar Beat periodically. So I wrote, what should we term this weekly insulin innovation? Maybe the centennial insulin, because of the 100-year history of insulin anniversary that's coming up, is the right term, is what I thought would be apt for that. So why do we need a long-acting insulin that lasts a week, and what are the benefits potentially? And we can talk about the potential disadvantages or challenges as well as we go. But one of the benefits is if you have a daily insulin, you have to inject it every day, so 365 times in a year. Whereas if you have a weekly insulin, you can inject it 52 times in a year. And that would mean that people will be more apt to initiate insulin. I'm sure in India, there is a lot of inertia in terms of starting insulin. I certainly see that in my practice. So I practice in Brampton, which is a suburb of Toronto. It can be called mini India because about 30 to 40% of people are actually South Asian origin, mostly of Indian origin. And insulin initiation is a challenge because people say, oh, do I need to start? Do I need to inject every day? So if you had a weekly injection of insulin, that'll be much better, easier initiation and less clinical inertia, as well as better adherence, because we know that people who are supposed to inject once or twice a day are not doing that as such as well. So the question is science. How do we achieve a prolonged duration of action or mechanism of action? How do we prolong the insulin to last about a week? So there's two kind of theories that are currently in development. So one is the Novo Nordisk way, which is add a fatty acid, a 20 carbon fatty acid chain to the insulin molecule with albumin binding. And when you bind it to albumin, then it slowly releases into the plasma over a week, and you get a long duration. The other potential kind of prolonged mechanism that is being studied is binding the insulin molecule to the Fc portion of an immunoglobulin. The immunoglobulin will then undergo lymphatic absorption, and through endothelial recycling, has a prolonged duration of action then. And many different companies are kind of in the race for this kind of a weekly insulin. I'll talk about Eli Lilly's molecule, which is termed BIF. BIF basically stands for basal insulin FC. Hopefully they'll come up with a better term to describe the insulin by the time this is about to launch. We don't know a whole lot about this insulin that is in clinical development at this time. So if you look at clinicaltrials.gov, these are some of the trials that are either completed or they are planned or recruiting at this time. I'll just highlight some of the phase 2 studies in this list, which includes people with type 2 diabetes and type 1 diabetes. So we should have more data coming up within the next few months about this BIF molecule that is in clinical development with Eli Lilly at this time. What we know or what we have been able to visualize at this time is this study, which is basically a one-time phase 1 trial looking at BIF versus placebo. So in BIF, in the graph, you can see the glucose nicely comes down with a prolonged glucose lowering up to 10 days is what is shown. And they also said there was a low incidence of hypoglycemia if it was a multiple dose and no injection site reactions, etc. But again, this is phase 1, and we need to see clinical trials to assess what are the benefits and if there's any safety concerns of this molecule. There's a second molecule from Novo Nordisk, which I discussed, and we know a whole lot about this molecule, and I'll discuss some of the clinical trials as well. Before I do that, this is the structure of icodec. Icodec is the name of the Novo Nordisk molecule that is in clinical development. What they've done is 3 amino acid substitutions. So they are marked by the red here, and that reduces enzymatic degradation. Also, receptor-mediated clearance is reduced because of these substitutions. But more importantly, this 20-carbon fatty diacid chain is added, which leads to albumin binding of this molecule. And the albumin binding is actually 10 times more potent compared to insulin detamir or levemir, as you may know it as such, right? So it's more albumin bound, creates a depot, and then slowly from the albumin is how this insulin molecule is released, getting the long duration of half-life. So here's a phase 1 study to show that icodec was suitable for a once-weekly use in people with type 2 diabetes. So what you can see is basically throughout the days of the week, so 1 to 7 with an injection at steady state, there is an even distribution of its glucose lowering effect as such. And you can see the median Tmax or when it is most potent appears to be around 16 hours. And then geometric mean T-half is 196 hours, which is over a week. Talking about phase 2, as Dr. Mishra pointed out, the first phase 2 trial was recently published. Dr. Julio Rosenstock from Texas was the first author, New England Journal of Medicine paper. I had a small contribution to make in this and was a co-author on this as well. Dr. Rosenstock presented this data at the EASD, the European Diabetes meeting earlier this year. And these are the results from that first phase 2 trial. So who were the people who were included in the first phase 2 trial? About 250 people who had an A1C between 7 to 9.5. And these were insulin naive people, so just on oral drugs as such. And they were then randomized to giving weekly icodec plus a daily placebo or a daily glargine U100 plus a weekly placebo. So it is, the highest level of evidence then, because it's a double-blind, double-dummy design trial that is comparing the two insulin molecules head-to-head as such, right? And of course, the endpoints were A1C, weight, etc. So what was the titration algorithm? The titration algorithm, and pay attention to this because this changes over time as the story develops. So for this first trial, the titration target was 70 to 108 milligrams per deciliter. That was the target, which we currently use in clinical trials. For example, for degludec, this was the target that was used as well, right? And the titration algorithm was actually borrowed from glargine EU100. So it was the titration of +2, +4 if the fasting sugars are higher than the target, or -2, -4 for glargine EU100 if there was hypoglycemia. And that was simply multiplied by 7. So +14 or -14 or +28, -28, because this is a weekly injection that is given once a week. So basically multiplied by 7. So what was the results? These are mean changes from baseline. So on the left-hand graph, you can see the primary endpoint, which was A1C. Basically, people starting at an A1C of around 8.1%. And the blue line, which is the icodec line, reduced A1C mean to 6.7% compared to glargine EU100, which is 6.9%. So about a 0.2% difference, but did not reach statistical significance. The weekly insulin dose is interesting because this icodec, despite its long half-life, it actually appears that there is less insulin dose needed to achieve the same glycemic control, at least according to this study. Of course, safety is a key feature of any new insulin molecule. So this was the hypoglycemia classification that was used. So this is the ADA classification as we know it. The level 1 hypoglycemia is between 54 to 70. Anything less than 54 milligrams per deciliter is what is called the level 2 hypoglycemia, or clinically significant hypoglycemia, which is more important as well. And then level 3 is anything that leads to unconsciousness or needing anybody else's help. So what was the results in this head-to-head comparison? So level 1 hypoglycemia was actually greater with icodec compared to glargine. So you can see the number and the events and the rates of hypoglycemia. But importantly, level 2, level 3 was similar. So there was 38 events in icodec and 32 events with glargine EU100. There was no significant differences in the level 2, level 3 hypoglycemia. Now the question is, how do we make this insulin even safer? And maybe we need to look at slower titration of the insulin and maybe not as stringent a target. So that was what was studied in this second trial, a phase 2 second trial of this icodec molecule. And I know there's a lot of numbers on this slide, but what I want you to pay attention to is not titration B and titration C, but just the titration A, because that's the titration that is going to be followed then in phase 3 trials for the future, or close to this titration is what is going to be followed. So what was this titration A? It was less aggressive. So it was the target was 80 to 130, not 70 to 108 for fasting glucose. And also the titration was not plus 28 or minus 28. It was minus 21, plus 21. So slightly slower titration was what was utilized. And again, the important thing is, does this then reduce the hypoglycemia or not? And I'm presenting all of the hypoglycemia, titration A, B, C, and then glargine. But what I want you to compare again is the titration A, which was the slower one, compared to glargine EU100. Basically, the numbers are similar, and there's no differences in either level 1, level 2. And fortunately, there was no level 3 or unconsciousness hypoglycemia. Okay, so that's good, in insulin naive people. How about those people who are transitioning from other insulins? How do we transition to icodec? And I had the opportunity to present this at the EASD meeting in October, September, October as well, basically switching from other insulins to icodec. And there were 3 arms in this. The interesting part was that there was a 100% loading dose arm. Basically, the first dose of icodec, when you transition, is doubled. And then second week onwards, the dose is halved again and then continue to titrate. Whereas the second arm was not doubled. So you transition dose to dose. If they were on 10 units of glargine, you transition to 70 units of glargine, and that without loading dose arm, and then continue to titrate. Versus, of course, glargine EU100 as the comparator as well. The other interesting part of this study is the double-blind use of CGM and the primary endpoint, which is time and range. And I know in earlier lectures by Dr. Ghosh as well as Dr. Jyotidev, you heard a lot about the CGM and time and range. So I'm sure you're familiar with these concepts for now. So time and range that the primary endpoint was looking at was 70 to 180 milligrams per deciliter at the end of the 16-week trial period. So this is the time and range, the primary endpoint. You see the baseline here. So baseline before transition, before the beginning of the study, it was around 54 to 58, 59%, which is low. And then it increased, especially in the loading dose arm, this was much higher. So it was higher than glargine by about 8%, and it met the targets. Remember the target of more than 70% that is recommended to be within the target of that 3.9 to 10 millimoles per liter or 70 to 180 milligrams per deciliter. That was achieved in the icodec with loading dose arm. I think more importantly and more telling is this graph also, and why a loading dose is required. Conceptually, why a loading dose is required is because of the long half-life, a 7-day half-life. You need 3 to 4 weeks for it to reach its steady state, right? And so for those 3 to 4 weeks, when you transition, you need a higher dose from the beginning to make sure that you reach that target. And so that was what was done. And then in this, without loading dose arm, you see a fasting sugar went up initially, and then of course titration brings it down. Whereas the light blue, which is 100% loading dose, it did not increase and remained at the same level as the glargine comparator. And then hypoglycemia, I will just say there was no difference at all in any of the levels of hypoglycemia. Whether you gave loading dose or not did not change the hypoglycemia as such. So summary of icodec phase 2 trial program. Basically, this program suggests that this insulin has similar glucose lowering effect and safety profile. And it is the loading dose in transition is safe and relevant as well. And I think the titration algorithms is very helpful when the phase 3 program starts early next year, which will include comparisons to degludec as well as glargine U300, as well as potentially in a type 1 diabetes population and a basal bolus setting as well. So overall, I think there is a huge need of a weekly insulin. It'll be very beneficial to the patients as well as for us as clinicians. The initial data, at least from icodec, is quite safe and robust. Of course, the benefit is 52 injections in a year rather than 365 injections in a year. And of course, we need to continue to look at safety as well as efficacy compared to newer generation insulins in the phase 2, phase 3 programs. And with that, I'll hand it back to Dr. Mishra, and I'm happy to answer any questions, or these are some of the generating discussion points that I thought we could start off with. What's your impression, Dr. Mishra and others, as well as the attendees as well, in terms of is this going to be useful? Do you think there's some problems that you can foresee, or which patient population do you think will be the right patient population for this? Thank you.
Harpreet, that was wonderful lecture. I'm sure these questions which you have put will take another 10 to 15 minutes, and I would like to have a debate on this next time when we invite you. But for the time being, there is a quick question here. And that is something which will be asked more often the moment people hear about this. Not many people know about it at the moment. Is that when will it be available to the public in the commercial manner?
Yeah, excellent. Of course, depends on the trials. So the trials with the phase 3 trials with icodec are supposed to start in January, and hopefully will be published and submitted to the regulatory agencies in 2022. And then hopefully in 2023 is, hopefully that's when this may become available. With the other insulin, BIF, probably a year or so later after that, so 2024 or so.
Yeah, what Indian patients often ask when I start them on the basal insulin once a day. They say, doc, do you have, Hindi में कहते हैं कि साहब आपके पास एक हफ्ते वाली insulin नहीं है? वो, we were like, I heard that, you know, they've been hearing for 10 years that there is a once a week insulin. So now you have made the things in a very solid manner. You have investigated, you have got a very good paper out of it, and I'm sure you will keep up this good work, because as Jayant has commented in the chat box, that this is going to be blockbuster, absolutely blockbuster. So thanks, Harpreet, for joining us. We'll, as you said that you want to join us, we want to call you more often, and it's a pleasure having you with us. Thank you so much.
Thank you. Have a good rest of the symposium, as well as have a good weekend and stay safe. Thank you.
Thank you. We go on to the next lecture, and that's by my dear friend whom I know for last 20 years, since I was in UT Southwestern Medical Center at Dallas, and I got exposure to his oratory at that point of time. He used to take journal clubs for the students, and he was very, very clear and very effective in sending messages. He's now, of course, become more distinguished. He's in Mayo Clinic, Rochester, and he's done a number of studies on lipodystrophies and many other metabolic diseases. So welcome, Vinay. We wanted to invite you to this platform for quite some time, and I'm sure you will continue to do the studies which are path-breaking in Mayo Clinic, in the various diseases, but more importantly, we wanted to hear something that you have published recently, management of hypertriglyceridemia.
Thank you very much, Anup. I know this is a virtual seminar, but I just wanted to say that my appreciation for you and the enthusiasm is very real. It is indeed a great pleasure to be speaking today on management of hypertriglyceridemia. Well, the broad objective is to discuss the approach to patients, but in between, I'll try to include a little bit on the diagnosis and classification, as also the causes and consequences of hypertriglyceridemia. We'll do this in the backdrop of two case discussions. Now, here's the first one. So this is a 45-year-old gentleman, and he comes for a general medical exam. This is just a health mela, and so he is on no medications. He has no other problems. He gets a lipid profile done, and that's what it shows. So he's got triglycerides of 762. His cholesterol is okay, 221, HDL is 42. But here's the kicker. Now, upon further questioning, he says that just before he came in for the blood test, he had 2 idlis and a vada 2 hours before the test. And, you know, this is not your, the kind of small vadas that you get in Delhi. So this is the South Indian huge vadas that we get there in all our darshinis there. So he had one of these things. So what should we do now? Okay. So should we be repeating a fasting lipid profile because, you know, his current lipid profile is completely useless? Or should we do this after we have advised him like 4 to 6 weeks of lifestyle changes? Or is it time to start medications anyway? Okay, so, and should that either be a fibrate to prevent pancreatitis in view of a severe hypertriglyceridemia, or should we start a statin for cardiovascular protection? Okay. Now, I don't think you can actually vote. And anyway, I'm actually right now in the United States, and we are sick of voting and counting votes. So I will proceed. And so as you know, the question here is really, should we or should we not be getting a fasting lipid panel in patients with dyslipidemia? And if you look at the guidelines, so these are the guidelines from the Endocrine Society, and more or less that's very similar to the other guidelines as well. They're quite categorical. They do say that a fasting lipid panel is necessary, especially for the diagnosis of hypertriglyceridemia. Now let's dig a little deeper into it. Why? Is it because the non-fasting lipids are not, like the non-fasting triglycerides, are they not useful? So this is data from the Copenhagen Heart Study. And quite clearly, as you can see, as the non-fasting triglycerides increase, the risk for myocardial infarction significantly increases. So non-fasting triglycerides really carry a lot of information. They're a very good marker for atherosclerotic cardiovascular disease. In fact, we should push the envelope further and ask the question is non-fasting triglycerides a better marker than fasting triglycerides? And surprisingly, the answer is yes. And this is provided by results from the Women's Health Initiative study. So here they had triglyceride levels measured at different time intervals after the last meal. I mean, there was no, they would just measure the triglycerides, and then on a questionnaire, these subjects would indicate when was their last meal. And what we can see is the triglyceride, which was measured 2 to 4 hours after the last meal, that was the best indicator of the risk for ASCVD. The traditional fasting lipid panel, which is the triglyceride that's measured 12 hours after the last meal, is almost useless. This does not convey any information on the risk for cardiovascular disease. Well, let me qualify that. Is fasting triglycerides really an independent risk factor or not? So the best data, of course, would be from the Emerging Risk Factors collaboration. This probably is the largest database we have. This is about 60, it's an amalgamation of 65 different trials, has more than 300,000 patients. And yes, as the triglyceride levels increase, the fasting triglyceride levels increase, the hazards ratio do increase. But when you adjust it for non-HDL cholesterol, it literally falls flat. So serum triglycerides, fasting triglycerides, we still don't completely understand whether it is an independent risk factor. Whereas on the other hand, non-fasting triglycerides clearly are. And then we have some more very fascinating data recently, which has been available from the GWAS studies, that's the Genome-Wide Association studies. And what these have shown is that people who are genetically prone, people who have genetic variations that lead to a high non-fasting triglycerides do indeed have higher cardiovascular risk. The other thing that is seen in these patients is they have higher levels of remnant lipoprotein cholesterol levels. Now, what's this remnant lipoprotein cholesterol? So if you remember your biochemistry days, so the two primary triglyceride-rich lipoproteins are the VLDL coming from the liver and the chylomicrons coming from the intestines. So these TG particles undergo initial hydrolysis by the lipoprotein lipase, and then we are left with these smaller, relatively cholesterol-enriched particles, the remnants. These could be either the chylomicron remnants or a slew of particles from the VLDL, what we call intermediate density lipoproteins. Now, some of them get further hydrolyzed to get the LDL particle, but most of these are actually cleared by the liver, usually an ApoE and an LDL receptor-like mediated process. So it is these remnants which are in abundance in people with hypertriglyceridemia, especially people with postprandial hypertriglyceridemia. And again, this is data from the Copenhagen Heart study. So as the non-fasting triglycerides increase, the remnant lipoprotein cholesterol level increases. And then we have other data clearly showing that this is extremely atherogenic. So these are in patients who are already on statin treatment and have good LDL cholesterol. What determines their survival and their overall cardiovascular risk is their remnant lipoprotein cholesterol levels. So with higher levels of remnant lipoprotein cholesterols, so they fare much worse. So the long and short of what I'm trying to say is this. Serum triglycerides themselves, especially the postprandial triglycerides, the triglyceride molecule is actually a very, it's really not a bad thing at all. So it's a very, it does not cause atherogenesis, it does not cause inflammation. But unfortunately, in people with high postprandial triglycerides, they also have high levels of remnant lipoproteins, which are enriched in cholesterol and which probably cause atherogenesis. So here's my lipid droplets of wisdom, if you may. The health risks of hypertriglyceridemia really depend not on just the triglyceride level, but more importantly on the nature of lipoprotein particles which are associated in these conditions. In people with moderate hypertriglyceridemia, that's triglyceride levels say around 200 to 500, they primarily have these remnant particles which predispose to atherosclerosis. On the other hand, patients with severe hypertriglyceridemia, those where triglycerides are in the thousands, here we have accumulation of these large chylomicrons and to some extent the VLDL particles. They do not cause atherosclerosis. On the other hand, they cause microcirculation, blockages, sluggish circulation in the pancreas, fatty acid oxidation, and so on, and cause pancreatitis. Now let's actually get back to non-fasting lipids and pancreatitis as well. And again, this is data from the Copenhagen Heart study. And as we can see, non-fasting serum triglycerides are very good at predicting the risk for pancreatitis as well. So it's not just simply ASCVD, but also pancreatitis. The risk is very well predicted by non-fasting triglycerides. So these are some more nuggets of wisdom. Non-fasting TG is a better predictor for ASCVD. Non-fasting TG levels also predict the risk for pancreatitis. But unfortunately, here's a sad point about everything. We do not have any standardization or reference values to interpret these non-fasting triglyceride concentrations. Like, we don't know what is the best time to measure it. Is it after 1 vada? Is it after 2 vadas? And how do the levels change? And what levels actually predict the risk? Like, how we have for glucose. We know that 75 grams of glucose, 2 hours after that, this level predicts the risk for diabetic retinopathy. We need similar standardization for triglyceride levels. And I think then some of this mystery about hypertriglyceridemia and heart disease will be clarified. So because we don't have this, we still have to measure triglycerides after a 10 to 12 hour fast. So let's get back to the patient. So we did this. So we got a repeat fasting lipid panel, and this is what it shows now. So his triglycerides are slightly better, but as you can see, he's still not out of the woods. So his triglycerides are 434, and his cholesterol and HDL has not changed. Cholesterol is a tad bit better. This time I also obtained an ApoB, and his apolipoprotein B levels are 82, okay, which kind of corresponds to an LDL cholesterol that's in the 90s. Okay. And then we had talked to him, and he has said in the past 4 weeks he has avoided all junk food and he's not drinking alcohol. He's really optimized all the lifestyle factors. But he says he spoke with his father, and his father has also had hypertriglyceridemia, but there is no heart disease in the family. What should we be doing now in this circumstance? So he's got hypertriglyceridemia, presumably familial, and his ApoB is 82. So your next step, in addition to encouraging this healthy lifestyle habits and dietary consultation, is, so basically the question is, should we or should we not be doing pharmacotherapy in addition? And if it is pharmacotherapy, what's the best medication? Should it be a statin? Should it be a fibrate? Should it be omega-3 fatty acids? Or do we need additional testing? Should we get genetic testing and decide on therapy based on these? Yeah. Again, we'll skip the voting bit. So for those of you who would have thought about obtaining genetic testing, okay, so let's address that one, because that's not the answer, okay? So I would really be doing nothing. And the reason is this. He does have familial hypertriglyceridemia, okay? So we are going to be talking about the familial chylomicronemia. That's very different. That's very dramatic, and I think most people know about it. And that's very rare as well. But if we look at primary hypertriglyceridemia, the common causes, there are generally 2 major causes. One is the familial hypertriglyceridemia, and the other is familial combined hyperlipidemia. And I think it's important to make this distinction clinically because the management is quite different. Both of these are very common, okay? Something like more than 5%, 10%. So this is quite common. We see this all the time. But the problem is they are polygenic. We don't have a single gene which has been identified. So unfortunately, there's no one genetic test which we can do, which will give us information or which will help us make the diagnosis. There are some subtle differences in the pathophysiology. People with familial hypertriglyceridemia, they basically pack a lot of TG into their VLDL particles. Whereas familial combined hyperlipidemia is primarily characterized by increased ApoB production. That's the protein backbone for all the VLDL and the subsequent IDL, LDL, and so on. The triglycerides are elevated in both, but in FCHL, we can also see variable elevation in cholesterol. But it's very variable. So at different times in the same family and in the same individuals, we can get either elevations in cholesterol and triglycerides, and we can't really hang our hat on that. But what will really help make this distinction is ApoB levels. Now, I don't generally get ApoB levels all the time, and it's an extremely useless test to get in people with hypercholesterolemia. If you have somebody with FH, don't do any advanced lipoprotein profile testing. So high LDL is good enough. But in people with hypertriglyceridemia, generally I go by the non-HDL, But the one time when an ApoB is probably extremely useful is in trying to distinguish between familial hypertriglyceridemia and familial combined hyperlipidemia. And the reason we should make this distinction is because FCHL is extremely atherogenic. So these people probably have almost the same risk as people with familial hypercholesterolemia. So when I see people with a strong family history with an elevated ApoB level, that's when we need to be extremely aggressive and start them on possibly statins and maybe a fibrate as well. Whereas if there is no family history and if the ApoB levels are normal, this is the old Fredrickson type 4 hypertriglyceridemia, which is possibly a benign entity, and we really don't need to be doing anything else except to avoid severe hypertriglyceridemia and pancreatitis in these patients. So let's now move to pharmacotherapy, and this we will do with the other case. This is just like any other day in the office. So you see this gentleman, he's 64, he's got type 2 diabetes, hypertension, and known coronary artery disease. He's on insulin, metformin, statin, ACE inhibitors, and aspirin. And again, this is one of your good days in office. So he's followed all your advice. He does aerobic activity, he does not smoke, no alcohol. And then he is obese, but then his weight has been stable, blood pressure is okay. This is his lipid panel. So his cholesterol is 206, triglycerides is 320, HDL is 46, and his LDL cholesterol is 96, A1C is 7.1%. So what should we do in people like this? So established heart disease, type 2 diabetes, optimized in terms of lifestyle interventions, and has an LDL of 96, triglycerides of 320. So should we intensify their statin therapy? Should we add Zetia? Should we add a PCSK9 inhibitor therapy or fenofibrate or omega-3 fatty acids? Now, again, this is one of those instances where you're probably not going to be wrong with any of these picks, and we might sequentially do all of these. But then, since we are primarily focused on triglycerides, I will discuss on the fenofibrate and the omega-3 fatty acids. So based on the current data that we have, probably the best option would be to add an omega-3 fatty acid, and it's not any omega-3 fatty acid. I'm really very privileged to have Dr. Ganda also listening to this. So, and I would really appreciate his insight. But what the REDUCE-IT trial really clearly showed was that adding this particular omega-3 fatty acid, that's EPA, icosapentaethyl, this was really, to my mind, it was very, very striking, the results. So this is now more than a year old. And if for those of you who have followed it would know this, so this is a large multi-center study, randomized to either giving 4 grams of EPA versus a placebo. And all of these patients did have hypertriglyceridemia, the moderate hypertriglyceridemia. So the median baseline TG was 216. And this is what is very, very striking. The absolute risk reduction was 5%, and the relative risk reduction was 25%. So even in the very good placebo-controlled statin trials, we never see an absolute risk reduction of 5%. So in patients who are already very well optimized in terms of current medical therapy, to get an additional 5% absolute risk reduction is really very, very striking to my mind. And that's what the REDUCE-IT trial showed. Now, I still don't know how this, what is the underpinnings of the study, because it's probably not just omega-3 fatty acids and triglyceride reduction, because a very similar study, which was designed in a very similar manner, the STRENGTH trial, but this looked at combination of DHA and EPA, and this had to be stopped for futility. So it seems to be something to do with EPA, and in fact, the post-hoc analysis just seemed to suggest that the benefit closely correlated with the levels of EPA. So there is probably much more that we need to learn, but as of now, the one way to reduce further risk is probably by EPA and 4 grams. Now, the other bigger question is about fibrates. Okay, so what about fibrates? Do they lower cardiovascular risk? Now, we clearly know that they do. In placebo-controlled trials like the VA HIT, yes, it did. But what about as an add-on to statin therapy? Now, remember, we were talking about the remnant lipoproteins being very atherogenic. And we have very good data showing that fibrates are very good for reducing the postprandial remnant lipoprotein cholesterol levels. So this is the graph. So this is with the fibrate, it's almost close to the normal lipidemic people, and this is the integrated area under curve. And fibrates seem to do a better job than statins when it comes to reducing this remnant lipoprotein cholesterol levels. This is comparison between fenofibrate and cerevastatin. In terms of clinical data, we don't have very robust data. So this is rather an observational study in post-ACS patients, where patients who were treated with combination of statin and fibrate did better. They had greater survival than patients who were on statin monotherapy. Now, however, our clinical practice is largely based on randomized control trials. And probably the best randomized control trial we have is the ACCORD trial. Okay, nothing new. You've probably seen this data many times before. So the ACCORD trial, it randomized these 5,000 patients with type 2 diabetes to either simvastatin plus fenofibrate or simvastatin alone. And the long and short is that it did not show any significant benefit. So the hazards ratio is 0.92 and the 95% confidence interval spans unity, which is why we think that fibrates are probably not effective when added onto statin therapy. But if we dive a little deeper and look at the lipid eligibility criteria here, they just had to have triglycerides below a particular level, below 750 or below 400. And so at the end of the day, if we look at all the people who are enrolled in this trial, the median triglyceride level was only 160. Only 17% of the patients had high triglycerides and low HDL. That is, only 17% of the patients were the kind of patients that you and I, when we see in clinic, would have actually given a fibrate. And if we look at the data in just these 17% of the patients, that is people with triglycerides greater than 200, well, they did have a significant benefit. And this is not just this one trial. So if you look at across all the fibrate trials, indeed, some of them did benefit, some of them did not. But the subgroup of patients with high TG, there was a uniform benefit. So, this is probably my last lipid droplets of wisdom. So subgroup analysis of multiple fibrate trials do suggest benefit of adding fibrates to statins. However, there is no mortality benefit. And as we said, EPA 4 grams per day has been shown to reduce cardiovascular risk. This is my approach to patients with hypertriglyceridemia. So I first make sure that it is a fasting lipid that is in case it is high. And then whether it is moderate or severe hypertriglyceridemia, it's very important to screen for secondary causes and to address them, especially diet. I see that there's a talk tomorrow on how to Indianize the Mediterranean diet. Okay, I think that would be extremely useful, and you can consider my talk as a trailer to that. Okay, so nothing about triglycerides will be useful unless you have the optimal diet. And then once we confirm hypertriglyceridemia in patients with severe hypertriglyceridemia, I start pharmacotherapy with either a fibrate or an omega-3 fatty acid, primarily to reduce the risk of pancreatitis. And in patients with moderate hypertriglyceridemia, I would always start a statin with or without a fibrate, depending upon their risk. So in conclusion, hypertriglyceridemia is actually the most common lipid disorder encountered in clinical practice. Now that's in US. This is based on the enhanced data. I'm sure in India, it's even more prevalent and even more relevant. And diet and other secondary factors need to be addressed in all patients. Primary TG lowering pharmacotherapy should be, of course, used to lower the risk of pancreatitis in those with severe hypertriglyceridemia and in combination with statins. Statins still are the primary go-to in patients with moderate hypertriglyceridemia for cardiovascular risk reduction. And finally, looking forward to, I'm trying to book my ticket for next year as well. So there are a lot of novel triglyceride-lowering therapies on the horizon. Volanesorsen, which is an anti-ApoC3, has already been approved in Europe, but the FDA did not approve it because of some side effects. But these are on the horizon, and these are likely to change some of our lipid-lowering therapy practices. Thank you very much again.
Thank you. That was wonderful lecture, very clear. And the last slide from your publication in BMJ was excellent, and I'm sure will be very well understood by all physicians. Now, a quick question to you is, you said niacin in your last slide. the role of niacin has diminished over a period of time. So, what do you think? Should we still use niacin in patients who are not responding to fenofibrate, omega-3 fatty acid, and so on? What is your
Not for cardiovascular risk reduction. So I think the data is quite clear. So we would never use niacin for cardiovascular risk reduction. Now, if somebody is having type 5 hyperlipidemia and is having pancreatitis and you're throwing the kitchen sink at them, then yes, perhaps. I have almost completely stopped using niacin. Most of these patients with type 5 have uncontrolled diabetes, and so niacin would not be a good drug for them. So no, the last slide was volanesorsen, not really about niacin. So
yeah, it's not even available anymore in India. So we have only fibrates and omega-3. So thanks, Vinay. That's wonderful.
My pleasure.
It was crystal clear, very well understood by everybody. Thank you for coming, and we'll see more of you in the near future. Thank you so much.
Thank you, Dr. Mishra.
Thank you, Vinay. Now we move to the last lecture, but not the least. It is my colleague Jayant today, who actually joined the first. He's been at it for last couple of hours. He's listened to every lecture and responded or asked question on every lecture. That is the type of concentration that he has. But that concentration was evident 25 years back when he did thesis with me in Ordinary Institute of Medical Sciences and did cognitive function in diabetes, and which was published subsequently in Diabetes Care, one of our first publication in Diabetes Care, and it was wonderfully done. I still remember at that point of time, nobody knew much use of computer, and he was very, very good at computer and his statistics, and which he carried on to the United States. And he's become very distinguished in the United States. He's been president of clinical endocrinologists in the southern states, and he has a very good practice in Tupelo, where I happened to visit. He kindly invited me there, so I could see how much is his knowledge and his hold on the patient. So thank you, Jayant, for joining us here. And your lecture is, I know, always interesting, and this is going to be very interesting, and we are eager to listen to it. Jayant.
Thank you. I started early, enjoyed all the talks, but the one talk that is going to have the most immediate effect on my life is Sugandha's talk on mangoes. And this is the best I can manage in the United States in mid-November. My mango, that will be my dessert tonight. Thank you so much, Sugandha, for sharing all that information. I have been privileged to be a student of both Professor Ahuja and Dr. Bajaj during my time as a student at All India Institute of Medical Sciences. Dr. Mishra, also my mentor, asked me to speak on diabetes in the young adult, a sea of possibilities. Over the last several decades, the prevalence of obesity has exploded in the children and adolescents, causing an increase in trends of chronic metabolic disorders such as type 2 diabetes in younger and younger populations. Dr. J.S. Bajaj was famous for his evening rounds, which used to be so educational. I often remember him saying, "Eyes don't see, which the mind does not know." My objective for this lecture is to discuss how different pathophysiology is involved in causation of diabetes and how having that knowledge will impact our treatment approach to our patients. Audience participation question number 1, if you can type on the question box the name of the celebrities with type 1 diabetes. And the second question would be, what is Ms. Theresa May wearing in the back of her arm? while you answer these questions, I will discuss type 1 diabetes. Autoimmune injury to the insulin-producing beta cells in the pancreas lead to significant hyperglycemia and sometimes life-threatening ketoacidosis. Polygenic in nature, type 1 diabetes can often be precipitated by environmental triggers like viral infections, including possibly COVID-19. Fawad Khan, Sonam Kapoor, and Nick Jonas were all diagnosed during teenage years with very typical presentation of type 1 diabetes. However, Ms. Theresa May had a different and unusual presentation. As Home Secretary at age 56 of Ms. Theresa May presented to her general practitioner with symptoms of polyuria, polydipsia, and weight loss. I'm having some technical difficulties. Can you all see my slide set?
We can see your slide, but the whole screen we can see. So you can go on with the same. We can, even if it is like this is fine.
Thank you, thank you. So she was noted to have high blood sugars and diagnosed with type 2 diabetes and sent home with oral medications. Theresa May went for several weeks with continued hyperosmolar symptoms before somebody correctly diagnosed her with type 1 diabetes and started her on insulin therapy. Latent autoimmune diabetes of the adult, or LADA, is a variant of type 1 diabetes which shows itself at later age with slowly progressive hyperglycemia and can hence be confusing to diagnose at the beginning. There is increasing recognition of a term called double diabetes, where type 1 diabetes also has features of insulin resistance and metabolic syndrome, primarily due to weight gain and obesity. And some of these patients may require, in addition to insulin therapy, additional treatment with those drugs which are traditionally used to treat type 2 diabetes, like metformin, SGLT2s, and incretin-based therapies. Audience participation questions with who this actor is who lost 55 pounds to portray a castaway. Which movie did he act where he did that? And bonus question will be, what was the name of the volleyball in the movie, if anyone can answer? There will be a prize that Dr. Gupta has promised he will deliver. Type 2 diabetes starts with the core defect of insulin resistance, but we increasingly recognize various defects in insulin secretion that finally causes the hyperglycemia in this syndrome. Professor MMS Ahuja, who was HOD of endocrinology and metabolism at AIMS in the 1980s, would have been very surprised to see the recent Indian Council of Medical Research registry data, where 1 out of 4, a quarter of all diabetics who are less than 25 years of age are actually type 2 in India. The diabetogenic environmental factors like poor eating habits and sedentary lifestyle is probably playing a big part in this shift of demographic in which we are recognizing and diagnosing type 2 diabetes at earlier and earlier age. Almost 50 years ago, a group of very astute clinicians recognized that some young people who would otherwise look very typical of type 1 diabetes actually did not develop ketoacidosis without insulin, and interestingly, responded fairly well to oral sulfonylurea therapy. They coined the term maturity onset diabetes of the young, or MODY. Over the years, we have recognized several different single gene defects causing various variants of this disorder. Although not a very common disease, 1 to 2% of all young diabetics in the United States would have one of these genetic disorders. Data from India is limited, but interestingly, 12% of all high-risk screened patients in a specialty diabetes clinic in South India tested positive for one of these gene defects. The more typical of the MODY disorders are caused by single gene defects in pancreatic function. The pedigree charts are most characteristic of multiple generations of one side of the family being diagnosed with non-ketosis prone diabetes at an early age. Many of these patients will respond very well to oral sulfonylurea therapy for years after diagnosis. Eventually, they may need insulin after more pancreatic loss. The risk of micro and macrovascular complications with these disorders are similar to type 2 diabetes, and hence the treatment goal remains the same. We have to treat aggressively because their disease starts at a young age. MODY 2 is an outlier in this condition. Caused by a deficiency of glucokinase enzyme, enzyme which is responsible for secretion of insulin in response to ambient blood glucose levels. In this condition, the pancreas continues to produce insulin, but the blood glucose levels are set at a slightly higher level. As you can see from the tracings at the continuous glucose monitor tracings, the GCK MODY patients have almost parallel excursions of their blood sugar compared to those with normal physiology, but set at a 30-point higher level. These patients are asymptomatic. They do not develop diabetic complications and do not require medical intervention. The one special circumstance is when a young lady with MODY 2 is pregnant. Due to maternal hyperglycemia, the fetus may develop hyperinsulinemia with risk of macrosomia, and hence carefully supervised insulin therapy may be required in the last trimester to prevent big baby syndromes. Other than that, these patients do not require medical treatment. Secondary diabetes caused by pancreatic disorders has also been called type 3C diabetes by WHO. Repeated bouts of pancreatitis can lead to exocrine enzyme deficiencies manifesting as fatty stools or manifestations of vitamin deficiencies, eventually leading to endocrine dysfunction of the pancreas causing diabetes, many of which do not require insulin right away. The one thing to remember while treating patients with this disorder is to avoid incretin-based therapies such as GLP-1 agonist because of their own risk of causing pancreatitis. In tropical countries such as Bangladesh, India, and certain parts of Africa, a disease called fibrocalculous pancreatic diabetes has been described, characterized by calcifications of the pancreas. Cystic fibrosis, hemochromatosis, extensive pancreatic resection, or pancreatic cancer can also cause diabetes. Secondary diabetes can often be seen in certain endocrine disorders, such as Cushing's syndrome, acromegaly, hyperthyroidism, and pheochromocytoma. All of these are reversible after proper treatment of the underlying disorder. We as a profession often end up inducing diabetes in patients iatrogenically due to use of certain drugs. Long-term steroid use is the classic offender. Atypical antipsychotics such as olanzapine, high-dose thiazide diuretics, high-dose statin therapy may all be related to reversible hyperglycemia. Some of the protease inhibitors used as antiretroviral therapy for HIV can induce lipodystrophy syndromes, causing both severe hyperglycemia and severe hypertriglyceridemia. Immune checkpoint inhibitor therapies have dramatically changed the response to certain cancer therapies, but may be associated not just with hypoglycemia as evidenced by the first quiz question that Dr. Gupta had, but also some risk of inducing immune-induced type 1 diabetes, which might be permanent. The organizers of this symposium have done a lot of work with defining the interactions between type 1 diabetes, type 2 diabetes, and COVID-19, but a lot needs to be studied still, and I will encourage anyone involved in direct patient care of diabetics, consider joining the registry that is available on an international basis to gather more data. We know patients with type 2 diabetes have much higher morbidity and mortality when infected with COVID-19, and vice versa, COVID-19, which enters cells through ACE2 inhibitors, ACE2 receptors have been identified in beta cells in the pancreas and may be associated with long-term diabetes after recovery from the initial infection. Let's travel back in time a little bit and join in during one of the teaching rounds with Professor Bajaj. He was famous for picking up clues, reading between the lines, between when a medical residents will present history and physical with a patient. Age is becoming a more and more difficult factor to consider since younger and younger patients are being diagnosed with type 2 diabetes, and different variants of type 1 diabetes can be seen later in life. Ethnicity has a role to play in the kind of diabetes. A younger person with diabetes from Native American or East Asian ethnicity is much more likely to have type 2 diabetes as compared to a young diabetic of North European ancestry, where type 1 would be more common. Presence of severe hyperglycemia and ketoacidosis points toward insulin deficiency states most likely seen with type 1 diabetes or advanced cases of MODY where intrinsic insulin production has gone down. Presence of strong family history of multi-generational young diabetics points toward the MODY diabetes. We just saw that the past medical history and detailed history of drug use is important in differentiating secondary causes of diabetes. A young lady with irregular menstrual cycles and hirsutism suggestive of polycystic ovary is much more likely to have type 2 diabetes in the future. Darkening of the skin, increases and back of the neck, also known as acanthosis, and skin tags are signs of chronic hyperinsulinemia, most likely related to type 2 diabetes. very high triglyceride levels can cause subcutaneous lipid deposits as shown as eruptive xanthomas under the skin. The lady on the left side of this slide was someone Dr. Simha helped me with 15 years ago when he still used to work at UT Southwestern in Dallas. This poor lady suffers from acquired partial lipodystrophy syndrome, in which she carries most of her weight in the abdominal area, with her arms and legs looking fairly muscular, but falsely so because it is actually the loss of subcutaneous adipose tissue which makes her arms and legs so skinny. Dr. Simha was kind enough to provide leptin therapy, which was at that time under investigation for this lady, to which she responded fairly well. Professor Ahuja used to teach the students to be careful about false positive and false negative tests. And it is true that we cannot put 100% trust in some of the testing, but these tests may help define the kind and underlying pathophysiology of the diabetes that we're dealing with. C-peptide is a breakdown product of insulin that is a sign of how much insulin your own body is producing. Normal or high normal levels can be seen with type 2 diabetes, but very low or undetectable levels are typically seen with insulin deficient states like type 1 diabetes. The caveat to remember is to avoid drawing C-peptide levels during acute hyperglycemic states due to the concept of glucotoxicity, and it's best to treat our patients and recheck C-peptide levels 4 to 6 weeks after an acute illness to get a proper idea of how much their own pancreas is producing insulin. Autoantibodies against various antigens of the human beta cells do suggest strongly the presence of type 1 diabetes, and more importantly, the possible need for needing insulin therapy in the near future. So why is all of this important? Why do we need to try to differentiate when we are faced with atypical diabetic presentations? It's important for choice of therapeutic options. As we saw with Mrs. Theresa May, had we been careful about checking her antibody levels as presentation, we could have started her on insulin therapy right away and saved her from weeks and months of continuing to be hyperglycemic. Certain disorders like MODY2 actually do not need medical therapy. Patients with pancreatic insufficiency and malabsorption may need much higher nutritional macro and micronutrient requirements to compensate for the lack of absorption. Certain kinds of diabetes are very prone to have unpredictable and severe hypoglycemia, and use of continuous glucose monitoring may be an important safety measure in those patients. Screening for micro and macrovascular complications may be different at different times based on the kind of diabetes we have, and especially in those who are young and diagnosed with metabolic syndrome, screening and treatment for comorbid conditions like dyslipidemia and hypertension may save them from cardiovascular disorders at an early age too. And very important to remember, once you have diagnosed someone with monogenic diabetes syndromes like MODY, the strong penetrance of these autosomal dominant disorders behooves us to offer genetic testing and counseling for other family members. For those who are interested in digging a little deep, Dr. Mohan's group from Madras has a great summary review on diabetes of the young, approach to diagnosis and management that is available free online to download. This algorithm on this paper has been very helpful in my preparing for this lecture. And of course, the book that all enrollees to this symposium are going to receive for free, Diabetes with Delight by Professor Mishra, is a strong recommendation from my side. I dedicate this guide to the personalized care of the young adult with diabetes, to my parents, who are both physicians, as well as my teachers, Professor Ahuja and Professor Bajaj. Thank you so much for your attention.
Thank you, Jayant. That was fantastic. Very well informative to our young listeners, to our general physicians, how to segregate a number of possibilities which often come as type 2 diabetes. There's so many possibilities, and simple phenotype and simple investigation can differentiate it. That's excellent. Now, I have a question for you. In your practice, is LADA something which is commonly seen by you, or would you, when would you order anti-GAD antibody test in any person who's adult, has diabetes? When will you order? What is your suspicion in such patients to order the antibody test?
Thank you for the question. Thank you for the comments, Professor Mishra. LADA is seen fairly commonly in the North American population. I would say the prevalence is between 5% of those who are more than 35 years of age in North America have a variant of LADA, as evidenced by one or more auto antibodies being present in the serum, but more importantly, based on their response to therapy. These folks are usually lean, they require multiple daily insulin injections, are prone to ketoacidosis, and hence we have to be careful in picking them up from the lot of type 2 diabetes, which is prevalent in this age group. The problem that we are facing is due to increasing obesity, it is hard to tell apart who also have a component of insulin resistance in addition to underlying autoimmune type 1 diabetes or LADA. So to answer your last question, if I had an older adult who was showing very labile blood sugar responses, and especially if they have incidents of developing ketoacidosis, I will have a very low threshold of ordering autoantibody levels. GAD and insulin autoantibodies are the two that I commonly have access to in our clinical setting.
Thank you, Jayant. Excellent lecture, and you would be pleased to know till now we have attendance of 742 people, and it's 9:50 p.m. in India. That is the type of interest that your lectures and other lectures have generated. So thank you very much for joining us, and for our listeners, please log in again tomorrow. We have another session of excellent lectures, a few diet lectures, and lectures by international dignitaries. Please, if you're interested in getting the book Diabetes with Delight free, please email to Koel Datta. I had earlier projected that slide, but please note down her email, koelduttac@gmail.com. If you send her your message, she will ship you the book freely. So please do that if you're interested. And thank you all for logging in large numbers. Thank you all for listening and wonderful interaction on the chat box. And thank you, Jayant, once again for giving us the opportunity to hear you in this wonderful session and wonderful lecture. So thank you, everybody. We log off for today, and we'll join us tomorrow morning again. Thank you.